করছি আমার এই প্রথমটা আমি এখান থেকেই করি, আমার মনে হয় সবই সুবিধা হবে। তারপরে দেখা যায় আমি এটা প্রিন্ট আউট করতে চাইছিলাম, আমার প্রিন্টারটা হবে না, ওটা দিয়ে
ওদের মাইকটা মিউট করে রাখো, ওদের মাইকটা মিউট করে রাখো।
করছি তোমাকে যে আমি অন করে দিচ্ছি, বুঝলাম আমি এখান থেকেই করছি। আমার এই প্রথমটা আমি এখান থেকেই করি, আমার মনে হয় সবই সুবিধা হবে।
দেবাশিস শুনতে পাচ্ছ?
হ্যাঁ শুনতে পাচ্ছি।
ঠিক আছে, দেখা যাচ্ছে ঠিকঠাক?
আপাতত দেখা যাচ্ছে।
আমাদের একটা টেকনিক্যাল প্রবলেম হয়েছে, এখানে একটা মেশিন কাজ করছে না, হঠাৎ দেখা যাচ্ছে মেইন ডেস্কটপটা কাজ করছে না ফর সাম রিজন। দুদিন বাদে আজকে এলো তো, আমাদের মাঝখানে একবার ইউজ হয়েছে, কিন্তু তাই না আমারটাও নিয়ে এলাম, নিয়ে এসে এখন লাগাচ্ছি যাতে দুটো ল্যাপটপ অ্যাভেলেবল থাকে।
আর আরেকটাই অল্টারনেট কানেকশনও থাকা দরকার সবার।
হ্যাঁ,
গুড মর্নিং স্যার। गुड मॉर्निंग सर। चड्डा गुड मॉर्निंग, कैसे हैं सर आप?
गुड मॉर्निंग, गुड मॉर्निंग,
all good. Said I should be on time. Okay, Dinesh has also joined.
Good morning, Manoj, you looking nice and smart and handsome as ever.
I'm just following your instructions.
Thank you, like a good boy.
Yeah, absolutely. I got up early, had my
breakfast. Now I can see you.
I was just trying to.
There is some technical problem here, so it may be a few minutes before we can sort it out.
No, take your time. I'm waiting.
Get the print card.
MLC है, हाँ।
जो बता नहीं रहे कि डॉक्टर ने बनाई है। डॉक्टर जी ने बोला आपकी मेरे में वहाँ गया था, एमएलसी डिपार्टमेंट में डॉक्टर का नाम नहीं बता रहे को किसने बनाई है।
मिल जाएगा आपको, डोंट वरी, यू हैव द राइट टू गेट योर एमएलसी। आपका एमएलसी, मेरा बात सुनो, आपका एमएलसी आपको मिलना आपका राइट है। आपका जो एमएलसी बना है ना, एक कॉपी आपको मिल सकती है। अभी नहीं देंगे, आज नहीं देंगे, कल जब एमएलसी जब खुलेगा ना, कल बना हुआ था ना, आज संडे है भैया, आज तो रिकॉर्ड रूम बंद है, कल रिकॉर्ड रूम में आपको एमएलसी मिल जाएगा। आज तो कोर्ट बंद है, कल ही आपको पता चल जाएगा। वही आपके पास एमएलसी का रिपोर्ट है ना? है?
Not described. Neither bound is not described. Neither bound is not described. 5 digits is not described.
So you do one thing. Don't worry. I understand. आपका गुस्सा मुझे समझ में आ रहा है।
पुलिस वाले ने गाड़ी ठोकी, पुलिस वाली गाड़ी ने मैडम को मारा था और पुलिस वाले ने इन मैडम को।
कब हुआ एमएलसी, कितने बजे हुआ?
ये 8 बजे रात को पास हुआ। पुलिस वाले ने
कल रात को हुआ। अच्छा, देख के साइन देख के तो बोलना है उसे। एमएलसी में साइन, एमएलसी है आपके पास?
हाँ, एमएलसी तो आईओ के पास।
आ जाओ अंदर आओ।
ये सर मैं फोटो लाया, मेरी बाइक गाड़ी कर रही है, ये देखिए फोटो। ये इन्होंने सिंपल लिख दिया मैडम ने।
नहीं वो
और 5 डिजिट ये
दैट इज डिफरेंट। लैसरेशन इज सिंपल लेके देखिए वो दैट द डॉक्टर विल।
और सर ये मेरा ब्रदर इन लॉ संजय गांधी मेमोरियल डॉक्टर है, वो वगैरह जो सेक्शन इसमें 320 ये सेक्शन 328 में क्लॉज 8 के तहत इसमें कुछ नहीं लिखा हुआ।
आपका एमएलसी देखें कहाँ है? एमएलसी
तो मेरे नहीं है ना, एमएलसी तो दिखाई मेरे को आई होने कल रात को।
एमएलसी के साइन किए ना, कैसे समझूंगा किसने किया है?
हाँ मैं पुलिस बोल रहा हूँ, यहाँ पर डॉक्टर सीएम है, सर चीफ मेडिकल ऑफिसर और डॉक्टर चैटर्जी, तो एक बार से बात कर लीजिए। डॉक्टर साहब हैं संजय गांधी।
हेलो नमस्कार डॉक्टर मनीष, मेरा बात सुनो पहले, सबसे पहले तो मेरा बात सुनो। हेलो, हाँ आप भी सीएम हो, मैं भी सीएम हूँ। जब मेरा बात तो सुनो यार, जब आपके सामने कोई खड़ा, somebody is standing beside you and without taking your permission just dial up and give the phone as if I am sitting here to attend everybody's phone. Is this right? Do you think if it happens to you, will you feel good?
দেবাশিস ব্যাকগ্রাউন্ড গুলো এ করে দিও মনে করে, হ্যাঁ, টপ হবে ব্যাকগ্রাউন্ড গুলো হোয়াইট যেটা।
হ্যাঁ বলছি ব্যাকগ্রাউন্ডটা দিলে পিকচারটা কাঁপছে, আমি সেই জন্য ব্যাকগ্রাউন্ডটা অফ করলাম। মানে যখন ব্যাকগ্রাউন্ড আমি যখন ভার্চুয়াল ব্যাকগ্রাউন্ডটা দিচ্ছি
আমারটা কাপছে, আমারটাই দাও, দেখো আমারটাই দিয়ে দেখো।
এটাও তো পেয়ে যাবে।
কেন ইন্টারনেট তোমাদের পাওয়ারফুল নয়?
হ্যাঁ ইন্টারনেট তো পাওয়ারফুল না, ব্যাকগ্রাউন্ডটা কেন কাঁপছে সেটা আমি বুঝতে পারছি না।
ঠিক আছে, কিন্তু তোমাদের ওখানে হচ্ছে না, আমাদেরও হচ্ছে। আমার পিছনে দিয়ে দেখতে পারবে? আমার পিকচারটা পিছনে দাও। ব্যান্ডউইথ একটু কম আছে বলে এরকম হচ্ছে, নাকি পাওয়ারফুল নয় ইন্টারনেটটা বলে?
এই জন্য আমি বন্ধ করে রাখছি,
হ্যাঁ?
দিলে পরে একটা অন্যরকম হচ্ছে।
কি বন্ধ?
ব্যাকগ্রাউন্ডটা একটু প্রবলেম হচ্ছে, ঠিক আছে। ওদের একটা প্লেন ব্যাকগ্রাউন্ড জুম থেকে তো চুজ করা যায়, ব্যাকগ্রাউন্ডটা জুম থেকে একটা প্লেন ব্যাকগ্রাউন্ড চুজ করে লাগানো যাবে না? জাস্ট প্লেন হোয়াইট ব্যাকগ্রাউন্ড উইদাউট দ্য লোগো তো আছে, সকলেই অনেকেই তো করে দেখি।
আমি কি ওখানে লগ ইন করবো?
হ্যাঁ আপনি ওখানে
আমি বলছি এখান থেকে প্রথমটা করে নিই।
তাহলে তো আপনার এখানে লগ ইনটা
ভিডিওটা এখান থেকে চালানোর সুবিধা, তো এটা কোঅর্ডিনেট করতে সুবিধা হয়। তারপরে কিন্তু আমি ওখানে
দেবাশিস তোমার ছবিটা কিন্তু একদম ক্লিয়ার আসছে না।
করে এসে তারপর
দেবাশিস তোমার ছবি একদম ক্লিয়ার আসছে না তোমারটা।
আমার ছবি ক্লিয়ার আসছে না, এবার আসছে?
ভীষণ ভীষণ পেছনে
না না,
light টা
তোমার
দাও।
একটা বললাম না,
আমার
hazy
ছবি
আছে।
দেখে তো দরকার নেই,
আচ্ছা আচ্ছা
আমি তো ভিডিওটা অফ হয়ে যাবে। আমার
ঠিক আছে।
কিছু তো দেখতে দরকার নেই আমার।
স্যার যেখানে বসছেন ওই জায়গাটা দেখে
হ্যাঁ
নাও।
হ্যাঁ, ডক্টর রায় যেখানে বলছে সেই ভিডিওটা আসছে কিনা ভালো করে দেখো।
স্যারেরটা ঠিক আছে, স্যারেরটা ডক্টর মুখোপাধ্যায়টা একদম পারফেক্ট আসছে।
মানে একটু ইন্টারনেটটা স্ট্রং না হলে এগুলো ভালো আসে না।
না, আমার এখানে স্ট্রংই দেখাচ্ছে, আপনি দেখুন আমার এখানটা।
আমি জানি না, না স্ট্রং দেখায়, কিন্তু ওর কারণে
আমার তো এয়ারটেলের ব্রডব্যান্ড মানে ওয়্যার কানেকশন চলছে।
ঠিক আছে ঠিক আছে।
স্যার একটু মধ্যখানে আনুন আপনার ছবিটাকে, আপনি একটু সাইডে হয়ে গেছেন, আরেকটু মধ্যখানে। স্যার আরেকটু মধ্যখানে, স্যারকে আরেকটু মধ্যখানে করো।
আমাকে
না ডক্টর রায়কে, স্যার একটুখানি মধ্যখানে। দেবাশিস স্যারকে একটু মধ্যে করো। হ্যাঁ আরেকটু আরেকটু। ইয়েস ইয়েস, এটা ঠিক আছে, ঠিক আছে। ঠিক আছে।
Good morning.
Good morning, Sanjay. How are you?
Yeah, I'm good.
Good. Looking nice and fresh.
Pardon?
संजय पहचाना नहीं जा रहा।
अरे सर क्या बात है।
मैंने कहा मुनो जितने हैं सबको यूनिफॉर्म पहना दिया है। मैं टाइम पे नहीं आज।
The choice of the shirt is yours. The tie is we had for the tie. That's all.
व्हाइट शर्ट, सबका व्हाइट शर्ट।
तो संजय क्या हाल है?
बस बढ़िया, आप बताइए क्या चल रहा है?
Oh, good. No complaints. All so far so good.
Yeah, good, very good.
But
How are the hospitals doing?
Hospital is doing very well. Lot of patients are there.
Okay, but what about your department? I mean, the infectious disease ward is full. What about your ward?
Our ward is because 50% are diabetic.
So you are taking COVID patients, diabetic COVID patients in your ward?
No. They are in the COVID hospital, but now the beds are full, so we are taking another set of creating a ward actually. Those private ward are converted in COVID ward again. Means that again. New addition of the beds, approximately 150 beds actually.
Okay.
Originally, the COVID hospital has a 300 bed. This is a full.
Oh dear.
So that is there.
What about Manoj in Mumbai? Mumbai is the other hotspot.
Yeah. I mean, but I am out of COVID. I don't get into that. Hinduja is looking after a lot of COVID patients.
So you have a separate designated ward for that.
Elective work is very, very less now. I mean, surgeries are
Yes.
nil.
Yeah, everywhere elective work is actually we are unable to cope up with this emergency now, so you cannot plan the elective work now.
Even our outpatients clinics are very thin attendance in the outpatients, both in the hospital and in the chambers. Both of them are very thin attendance.
Yes.
So are we, Munojit, are we ready now, or they sorted out the problem?
No, the problem is sorted out. Let me see. I'll just get back to talking to.
और मनोज सर क्या हाल है?
बाकी ठीक है, सब चल रहा है। बस बीच में उषा से बात हो जाती है। एक आधा आई थिंक आई अटेंडेड वो मंजू का टॉक था उसमें IOF में, तो वो मैं देखा।
मैंने ट्राई कर रहा था पर हुआ नहीं, फिर छोड़ दिया थोड़ी देर। कल
वो इट्स देयर अवेलेबल फॉर 3 months, आप बाद में देख सकते हैं। इट्स अ गुड टॉक, उसने मेहनत की हुई है।
Dr. Mukhopadhyay, just a minute, sir. Disturb you. Dr. Mukhopadhyay, in the meantime, you can just check the chat box also. Someone have chat.
ASBMR कैसा हुआ?
ASBMR चल रहा है।
अच्छा, today is the last day?
No. It started yesterday only.
Okay.
11 to 15.
11 to 15. Okay.
Yeah, so तो कल उनका फर्स्ट डे था। कुछ में टॉक सुनना था शाम को, और हमारा एक ओरल प्रेजेंटेशन है वो एडल्ट बोन एंड मिनरल वर्किंग ग्रुप में, वो कल है। Monday night, Tuesday, मतलब अपना Tuesday early morning, 12:30 a.m.
Yeah. Yesterday night, about midnight, I heard a talk from the endocrine update on thyroid eye disease.
Hmm.
So the original guy who has worked on thyroid eye disease, ophthalmologist,
Hmm.
and he was the lead author for that trastuzumab study also.
अच्छा.
2016 का publication है. There
Hmm.
is not a good speaker, but a lot of information.
Yeah, every information is full everywhere. Now I don't know how much to read and where to read, how to read. That's
So
okay.
much of information.
But that is good that at least myself, like I am just sticking to diabetes and bone. That's it. So at least not much worry about what the things are going on. At least you can manage the patient. That's fine, but may not be every time up to date. So that is good.
Good morning, Dinesh.
Good morning. How are you? All well?
All good.
Nice to see all of you.
Hello, Jain साहब क्या हाल चाल है?
Dr. Sanjay Vadada is there. I can see.
Yes, sir. Yes, sir. Yes, sir.
Good.
Dada is covering everything.
Yes, yes.
Clinic
Where
में
is Dr. Ray? Dr.
Yeah.
Sabyasachi Ray.
Yeah.
So
सर आप तो एकदम पूरा रिवैम्प कर लिया. आप तो एकदम पूरा एकदम बॉम्बे स्टाइल में हीरो स्टाइल एकदम पूरा है स्टाइल पूरा.
अभी
Bombay is hot nowadays. What is going on?
बॉम्बे
इधर अभी 2 बजे के बाद बात करूं.
क्या कोरोना क्या कंगना इधर उधर सब चल रहा है.
एक जगह राजपूत का, एक दफा कंगना का.
हाँ.
मतलब ऐसे it's unbelievable यार. What they are talking and what they are doing. Well, possibly just diverting the attention away. So today we have 3 talks, no?
हाँ, we have
Yeah, there are three talks.
One thyroid, diabetes, and
Last is on respiratory failure in COVID.
okay, that's good. Yeah.
Screen এটা খুলে ফেলতে. I think now I've taken the mask off. Actually, there has been a problem. The main computer somehow is not working. That's why we had to do a lot of juggling around, and now changing the position and using one of the laptops. I brought my own laptop, which I normally don't. So that's how things are getting changed. But anyway, now we're probably okay. From our side, it seems to be all right now. So Manoj is smiling. After a long time, I can see his face. I've seen Sanjay.
I think that's probably a picture of, yeah, there you are. Good morning, Manoj and Sanjay.
Morning.
Good morning, Dada. Sujoy, क्या हाल है?
Yeah, nice seeing you all after such a long time.
Yes, yes.
At least I'm thanking my stars that I'm alive.
Oh,
But because you must be knowing, I went through a very bad phase. I lost my mother-in-law recently to
Yes,
COVID.
yeah, I know.
It's been a harrowing experience. So
Yeah.
So how's everything?
yeah, things are okay so far.
We are all staying together. That is good.
Yeah.
That's nice. The situation in Maharashtra is actually getting a bit out of hand now. We are getting so many cases nowadays.
Yeah, see, after Ganpati, lot of city people visited their villages. So they
Okay.
brought the disease to the village.
Right.
Earlier on, it was only in the metro city and the large cities.
What I found it very surprising is that it is even spreading in areas like Pune, which are basically not.
No.
I mean, they were not very congested areas. I mean, Bombay you can expect, but Pune is.
No. Pune also has got its pockets. See, there are pockets everywhere where people, get tendency. They all live together. So Pune also has their own pockets. So the participants would be having another separate link.
Participant have a separate link?
Yeah, panelists have a right to on their camera and microphone. Participant only hear see your picture slide and listen only.
Okay, and they can put in their question in the chat box.
Yeah, in the chat box.
এখানকার ছবিটা চলে গেল কেন? Now, what time is it now? 10:56. So far,
Logged in so far.
I think there are only 3 attendees joined us so far, as I can see from the list. So that's, as always, we always get delayed. Is Indian stretchable time, no matter what you say. I think we don't have enough people to listen to.
But I think we cannot wait indefinitely. We can give them at least 5 to 6 minutes.
Yeah.
And then after that, I think we should start it.
Let Shagurika and Shah join. I'll run them. They're going to join in a couple of minutes. And as soon as they join, I think we can start.
I don't see Sayok Roy. Where is he? Sayok is not in the.
No. I told both of them they are logging in now. That's what they said.
Sanjay, I can see some evidence of Sanjay. Sayak is probably coming. Now, I don't know what is 3 persons joined so far. It's nearly 11.
Joined.
Hello.
Okay, sir. Good morning, sir.
Good morning, sir.
Good morning.
Morning, sir.
Good morning.
Yes, sir. Good morning, sir.
So let us take this decision that within 5 minutes we should start the seminar.
Sure.
Sure,
Yes.
we should.
Sure.
I'm just waiting for Shagurika to join. As soon as she joins, I think.
The face of Dr. Riwari.
Unfortunately, I'll have to leave after introducing the first speaker and the chairperson because my son is appearing for the NEET today. So I'll have to.
Best of luck, sir, for him. Best of luck.
Yeah,
All the
I
best.
don't think any luck is going to do anything at the moment because he's going in a very casual manner. So he actually doesn't want to follow a career in medicine. He wants to take a basic sciences.
Okay.
The only reason he's going for it is if he can, by stroke of luck, score some good ranking. There are some good science institutes where he can get a direct admission. So that's why he's appearing.
Okay.
He doesn't intend to take up a career in medicine till now.
Okay.
Let's see somebody way from Delhi in the picture. So Delawashi is enabling Dr. Riwari to say hello to us, although he has registered as a participant. So I think if you are successful, we can say hello to him.
Good morning.
Surely.
Good morning, Dr. Sabyasachi, Dr. Jain, and everybody. Good morning.
Good morning. Good morning, Dr. Riwari. Nice to hear your voice.
I haven't yet seen your photograph, but I can hear.
My camera is not working properly, so I can send you my picture rather than live picture.
Your beautiful voice.
But mentally, we can visualize your face.
Thank you so much. Thank you so much.
It's nice to hear a beautiful voice from you after a long time. We haven't heard from you. But we had an opportunity, but your camera is not working. Maybe next time.
Yes, sir. But I'll be available throughout, so I'll be joining the session throughout today.
Okay. Okay.
Shall I share my screen, sir?
Right?
You just wait, we'll start and we'll introduce you.
Keep it ready. Keep it ready, and then when you want to start off the CMA, and then I'm sure you know.
Monojit sir, I think your voice is, appears to be much more clearer when you speak without the headphones. There's some problem there?
No, okay. Then I'll take off the headphones. Okay.
Yes, it appears to be much more clearer when you take off that headphone, generally.
Are we having any friends from Dublin joining us?
I think we can start now.
4 persons joined so far. I'm not sure whether they're the right. If everybody says to start, we can start. But it will be just talking in an empty hall sort of thing, which is always the case.
No, but the introduction is okay. I mean, let's start off. Otherwise, we won't be able to. I was just waiting for.
We cannot wait for people to join. If somebody is late, let him be late.
Yeah, Shagorika's joined, so I think we can start now.
Even Sagorika now. Speakers are there.
Good morning, Shagorika. Good morning.
Good morning.
Good morning.
There.
Incidentally, I tried logging in through my computer also, but it is not working. So I had to log in through my mobile. Because whenever I'm logging on to the link provided by Debashish, what is happening is that it is going back time and again to the webinar registration. And you're filling it up time and again, but then it's just simply not when it.
Everyone, today's morning, I have sent mail again, everyone, the link.
Yeah, the morning one worked fine today.
Yeah, I was okay. I was fine with me as well. Okay.
There's something wrong with the capture because the capture is not coming up.
Chat box working. I send a message in chat box.
The chat box is working. Some messages had come through.
So shall we start now?
Yeah, I think so. Shobhashita, I think we need to.
Yeah. So good morning and welcome everybody for this ICRCPI, the Indian Chapter Royal College of Physicians of Ireland webinar 2020. It's been very dark hours for the last 6 months, being completely subjugated by COVID. But nowadays, at least we're trying to break free from that. And as a part of this effort, the Indian Chapter of the Royal College of Physicians of Ireland is organizing this webinar. There will be a series of webinars in the coming months, and we expect all the members and fellows to join regularly. Today, we have got 3 excellent speakers and 3 excellent chairpersons to take you over for the next 1.5 hours. But before we start, I'll invite Dr. Shubhosha Chirai to say a few words and to give the welcome message from the President, Royal College of Physicians of Ireland, Dr. Mary Hogan.
Good morning, everyone. It's my privilege and honor to represent the Royal College of Physicians, the oldest medical institution in the world. This year crossed to 365 years. And Indian chapter was inaugurated officially in 2005. Since inception, we have been organizing regularly MRCPI examinations as well as CME, conferences and seminars by ourselves, and also in association with the organizations, institutions, and universities throughout India, and mainly in the major cities like Kolkata, New Delhi, Mumbai, Chennai, and also Siliguri, Gurgaon, and the neighboring country, Bangladesh. Unfortunately, the global pandemic conferences and seminars by ourselves, and also in association with the organizations, institutions, and
universities throughout India, and mainly in the major cities like Kolkata, New Delhi, Mumbai, Chennai, and also.
Sorry, I had to stop because there's a recorded message was coming. Anyway, unfortunately, due to this COVID-19 pandemic, over the last 6 months, our professional and personal lives were completely devastated and restricted our work and also personal life. During this new normal period, only thing was possible to communicate for academic pursuit was through webinar. Therefore, I am very pleased to welcome you all once again for this first ever webinar in internal medicine organized by the Indian chapter Royal College of Physicians, which is the first day today and will continue on the second week, Sunday of every month from now onwards. And I think we will learn a lot from this deliberation today, and we'll have a very useful take-home message. And now, without further delay, I would like to play the video message from Professor Mary Horgan, the President at Royal College of Physicians of Ireland. Over to you, Devashish.
Devashish, can we start playing the message of the President, please?
Yeah.
It was working so well the other day.
Yeah, always there is a technical hitch when you don't want it.
Can play that message from the original source instead of this presentation.
Do you want me to open my, how can I do that? Actually, it came in my email and then I forwarded to Indian chapter. I think he's trying to open that mail and get it going. Let's see, I think it's going to work now.
Hello, I'm Professor Mary Horgan, President of the Royal College of Physicians of Ireland and a consultant in infectious diseases. I was delighted to be asked to address you by my colleague and fellow Dr. Sabia from the Indian chapter. This has been a particularly challenging time for us as a profession and indeed for the society and the people for whom we care. Never before has such a health issue affected so many people globally, and we all are learning as we go along. Thankfully, we're in a better position now in Ireland than we had been in the months of, particularly in March and April, where there was a considerable lockdown, which had a huge impact on the mental and physical health of our society, but also has had an economic impact. I hope that within the coming months and year, that a vaccine will help alleviate a lot of the hardship that the pandemic has brought on our societies. The pandemic has afforded us opportunities to learn from each other and educate each other through different platforms. Certainly within the College of Physicians, we have used the platform of Zoom to provide up-to-dates on all things COVID-19, which has been particularly helpful for those who practice medicine, not only in Ireland, but all our international colleagues. I'm delighted that Dr. Sabia and my colleagues in the Indian chapter have continued this with today's webinar on September 13th. I hope that you have a great learning experience and that these webinars will be the start of many more to come. Wishing you kind regards from Ireland and from all the members, fellows and trainees, both in Ireland and internationally. Thank you.
Thank you for your time. Actually, as you noticed, as you heard, that Professor Horgan mentioned about many webinars organized by the college. If anybody is interested, please log into the Royal College of Physicians of Ireland and go to the actual portal and links. And now I hand over to Dr. Sujay Majumdar for further proceeding of today.
Right. Am I audible?
Yes, you are.
Okay, so without wasting much time, let us invite the first chairperson for today's session, Dr. Sanjay Vadara. Dr. Vadara is somebody whom I know personally for the last few years. He has been instrumental in getting quite a few of us enrolled in the Indian Society for Bone and Mineral Research, which is one of his areas of interest. But at the same time, today he is not chairing the session on anything to do with bone mineral research. He's going to chair a session on the thyroid nodule. Can we have the CV slide of Dr. Vadara, please?
Yes, it's there.
Sorry, it's not coming up actually. So basically, it's not actually coming up on my screen. It's because there's something wrong. Anyway, so basically, what we are going to talk about today is about the thyroid nodules. This is the CV slide of Professor Vadara. He's one of the leading faculties of PGI Chandigarh, and he has got many academic achievements to his credentials, more than 250 publications, contributed a chapter in the Williams textbook of endocrinology. He has got the Oration Awards for research in primary hyperparathyroidism in India in 2016 and 2019. He's a founder of Aditi, which is basically a social support group for young diabetes. He's an ex-secretary and the current executive of the Indian Society for the Bone and Mineral Research, and is the ex-secretary and chairman-elect of the Punjab chapter of RSSDI. And he's going to introduce the speaker, Dr. Shayak Rai. They're going to talk about a very interesting topic today, that is the approach towards the thyroid nodules. We know thyroid nodules often present to us with multiple diagnostic dilemmas. And to deliberate on that, I'll first invite Professor Vadara to introduce the speaker and say a few words on the topic.
Thank you, Dr. Sujoy, for the kind words and the kind introduction. And may I the CV slide of Dr. Shayak Rai. So in this session, Dr. Rai is going to talk about how to approach a thyroid nodule. And a brief about Dr. Shayak Rai is he's MBBS, ICRCPI, and he's a visiting physician at Medica Super Specialty Hospitals, Kolkata. And he had international poster presentation as well as many publications in national and international journals. And I know he's a very prolific speaker, and I'm very eager to hear from you on this important topic, that is thyroid nodule. The thyroid nodule is seen commonly on clinical examination as well as on the ultrasound examination. It is found that it is varying from 20 to 30% in variable population, much more common in the women as compared to the men, much more common in the iodine deficient area as compared to the iodine sufficient area. And it is very interesting that approximately 5 to 10% of these nodules are malignancy actually, and that's why we need a close understanding or the correct understanding about this thyroid nodule, how to approach it. I am sure Dr. Sai Roy will take us to this interesting topic. And now invite Dr. Sai Roy to please give his presentation on this important topic. Sai, please.
Thank you, sir. Thank you so much. So, shall I share my screen now?
Yes. Yes, please.
Host disabled participant sharing. I think I have to be the co-host. Devashishta.
Devashish makes I am the co-host.
Yes. It's now. Is there?
Yes.
It is visible right now, sir?
Yes, it is visible.
Okay. So today we'll be going through one of the very common things that we find in our day-to-day practice, that is a thyroid nodule, how to diagnose, or rather how to approach a thyroid nodule. If we see, the females are much more predisposed to develop a thyroid nodule, or rather we can find thyroid nodules much more in a female rather than a male. And the nodule will become visible when its size is more than 2 centimeters. And 50% of us, actually, of the normal population will have a thyroid nodule. So that might be called an incidentoma. So that is the reason why we do not recommend an ultrasound of thyroid for regular screening. It's only when you suspect something or you get a nodule, then only you think that, okay, fine, we can go ahead with a thyroid scan. That is an ultrasound scan, a high resolution ultrasound scan. And again, only 3 to 5% of the nodular are now found to be malignant, but might vary from place to place. So this is the causes of nodularity, some divided into benign causes and some of them are malignant, of course. So follicular adenomas, multinodular goiter, Hashimoto's thyroiditis, and simple cysts, colloid, be it colloid, hemorrhagic, or simple cysts. So all these will come under the heading of the benign thyroid nodularity. And while in malignant, we know we have the most, the best outcome, that there's a papillary carcinoma thyroid. We also have follicular carcinoma thyroid. We also have the medullary carcinoma thyroid, where we cannot, or where we actually have, the genetic screening is going on. We also have the most rapidly spreading, that's anaplastic and poorly differentiated carcinoma of thyroid. So it can just grow within days to weeks. So this is a gland where you can find the most slow growing one, also the highest growing one, that is the anaplastic cancer. So today we have to, when we are approaching, when we are getting a nodule, thyroid nodule, we'll be following this scheme. That is, we'll be taking the history and examination. These are two important things which should never be missed, because we have to take the history of increased thyroid cancer from the patient. Whether the patient had a childhood history of head and neck irradiation, whether there was total body irradiation for bone marrow transplantation, whether there was any exposure to ionizing radiation, whether there is a family history of PTC or MTC, that medullary thyroid cancer or papillary thyroid cancer, or the thyroid cancer syndrome are there in the family, like MAIN-2 or Werner syndrome or Carney complex. We also have to take the history, how rapidly the nodule is growing, whether anything which is growing very rapidly, like I said, anaplastic cancer just grow within days to weeks. So the rate of growth is very important. The associated cervical lymphadenopathy is also important. And also the fixity of the nodule to the surrounding tissue. That will mean the carcinoma might have invaded into the peripheral tissues, and also the focal cord paralysis or hoarseness of the voice. So these are things from the history that should be taken. And while examining the patient, we have to follow the age-old process, like from in front, also from behind. So that is very important, that you do not miss the examination purpose, the examination state. And you have to assess the thyroid gland for the volume and consistency. And when you find the nodule, you have to assess the size, the number of nodules, the location of the nodule, and the consistency. That is very important. So this is how you approach when you find a clinical detectable nodule or incidentally detectable nodule. So whether you have to go for a thyroid assessment. That is the most important thing, because on top of that, you will decide whether to go for an ultrasound or a technetium magnetic scan. If the TSH is high or is a normal part, is higher or in the upper part of the reference range, fine, you can go ahead with a sonography. But if it is low, then only scintigraphy is actually indicated. That's very, very important. Scintigraphy is not for all, only if TSH is low. That's very important. And thyroid ultrasound, of course, not for all, not for general population screening. It's only when you suspect a nodule, when you got the nodule on clinical examination, or in the patient's incidentally detected nodule, especially FDG PET. If somebody has got some thyroid nodule in FDG PET, then there is likelihood of a malignancy out there. So you have to evaluate that nodule properly. And when you're doing the ultrasound, because I'll be sharing the viewpoint of a physician, I'm not an endocrinologist. So what I will do, I will try to summarize what I do in my chamber and what we all physicians do. Because and there will be a time like when you get a Bethesda class 4 or class 3, when you might have to refer your patient to your senior endocrinologist, who will be deciding whether to go for molecular testing or not, or go ahead with straight ahead with excisional biopsy. So these are the ultrasound features. What do we look for? We look for hypogenicity, irregular margins, absence of halo or nodule of the nodule. We also see the increased vascularization, because we know tumors, malignant tumors always have increased vascular channels out there to supply the demand of their growth. And presence of microcalcification, that is also very important. That is also very important. And nodules higher, taller than wider, that is very, very important. When whether the person who is reporting the ultrasound, he should or must report all these things. Because if it is not there, whether it is taller than wider or wider than taller, maybe you have to redo an ultrasound from a specific person. So be aware of these things, how to report the ultrasound. And this is what you get when you get a high, so you can get a highly suspicious lesion, you can get an intermediate suspicious lesion, you can get a low suspicion by very low, or a simple benign lesion. So whom do you call a high suspicion lesion? Of course, if your lesion is a solid hypoechoic one with irregular margins and microcalcification and taller than wider shape and disrupted rim calcification, and of course, if there is any evidence of extrathyroid extension, then that is an indication where you have to go for a FNA or the final aspiration cytology, if from the nodule which is more than or equal to 1 centimeter. Who do you call intermediate suspicion? Of course, the lesion will be a hypoechoic solid lesion, but with a smooth regular margin and without microcalcification or a taller than wider shape. So you have to go again for a FNA when the lesion is more than or from the lesion which is more than or equal to 1 centimeter. Remember the size, the exact diameter, the maximum diameter is very, very important. That should be you have to be very specific on whom to go for FNA and whom not to investigate for it with FNA, because that will simply increase the burden of FNA. And low suspicion, of course, the malignancy rate becomes considerably lower to 5 to 10%. These are isoechoic or hyperechoic. Remember, those were hypoechoic. Now it is changing to hyperechoic, of course, with uniformity, and there will be no irregular margin or macrocalcification. For this, for the previous one also, it was up to 1. Now from this time onwards, you do an FNAC if it is more than or equal to 1.5 centimeter. And very low suspicion, like I said, can be just spongiform or a partial cystic lesion without any sonographic features like described before. Consider FNA only when the nodule is more than or equal to 2 centimeter, not before that. And observation without FNA is also a reasonable approach. And what about the benign one? You get a benign, please do not go for a biopsy. It's unnecessary for us and also for the patient. So this is the summary of recommendation of FNAC based on the ultrasound. You get a high suspicion lesion, you get an intermediate suspicion lesion, you go for FNA if both of them are more than 1 centimeter or equal to 1 centimeter. Low suspicion, I think we remember what are the low suspicion lesions from the ultrasound features that I shared just now. You can go for an FNA if it is more than 1.5 centimeter. Very low suspicion, of course, you can still go for an FNA, or you can just simply go ahead with observation, whether it's increasing or not, whether the consistency is changing or not. And you can go for FNA only if it is more than 2 centimeter. In benign lesions, just don't treat the patient unnecessarily. So FNA recommendation as per the size, like I said just now, intermediate and high, more than equal to 1 centimeter, low suspicion. On ultrasound, more than equal to 1.5. And very low suspicions, of course, more than equal to 2 centimeters. Of course, you can go for an observation. Less than 1 centimeter and with purely cystic characters, no need to go for an FNA. Like nowadays, we have a CORAD specification for our COVID-19. We also have a TIRAD specification for our thyroid malignancy or our thyroid reporting system from the radiological colleagues. So they will look into these points. How will they calculate the point? Depending on the composition of the thyroid gland, depending on the lesion, depending on the echogenicity, whether it's hypoechoic, very hypoechoic, or anechoic, depending on the shape, like I said. If it's taller than wider, then of course they will give you 3 points for that one: margin and echogenic foci. So these are the things which will get each one of them will carry certain points, and they will try to add up the points for you, for us, for the physicians, for the help of the physicians. For 7 points or more, of course, it's a highly suspicious lesion. That means the patient is highly likely to have some sort of malignancy out there. 4 to 6 points, again, moderately suspicious. Highly suspicious is 3 points, and 2 and 0 points, of course, no suspicion is there. So we do not go for an FNA. And this is when you order for a FNA, please mention that I need a Bethesda classification, or you can also go for a Thai classification by the Royal College of Physicians of Pathologists, or the UK Royal College. So category 1 is non-diagnostic. That means, of course, you have to prick the patient again, you have to do an ultrasound again. So benign. Number 2 is benign. 0 to 3% of malignancy, very low chance of malignancy. We do not further follow them up generally. Now the problem starts when you have 3, 4, or 5. Of course, if you have 6, there's frank malignancy. You don't have to wait. Just straight go ahead with your surgery. But what happens when you have 3, 4, and 5? These are the lesions on the Bethesda classification. Remember, this is the cytological reporting I'm saying. This is not the ultrasound reporting, okay? So this is the cytological reporting. Once you have done the ultrasound, you now go do an FNA from the appropriate lesion, and you find the cytological report mentioning that the patient has AUS, or atypia of uncertain significance, or FLUS, that is a follicular lesion of uncertain significance. That is a class 3, category 3 of Bethesda. Or a 4. Of course, when you have 4 and 5, it's quite clear that you have to investigate it further very urgently, or else you might just miss a lesion which is malignant out there. So this is just a comparison between the Bethesda as well as the Thai classification. I just wanted to tell you that up to 2 of Bethesda and up to 2 of our Thai classification, we do not have to worry much, because these are benign and rather non-neoplastic. But from 3 onwards, you have to be very vigilant on follow-up. So what happens when you recommend initial follow-up for the nodules with benign FNA cytology? So you got something in your ultrasound which is highly suspicious, but in your cytology you found it to be benign. So you repeat after 12 months. That's very important. You found nodules to be having low to intermediate suspicion. You repeat the ultrasound after 12 to 24 months. And what happens if your FNA nodules do not meet the FNA criteria? The nodules which are highly suspicious in the ultrasound pattern, repeat the ultrasound only after 6 to 12 months. Nodules with sonographic features of low to intermediate, like I said. So you divide them: high suspicion, low to intermediate, very low, and of course benign. So low to intermediate, you intervene after 12 to 24 months. Nodule more than 1 centimeter with very low suspicion, of course risk is not known. If the risk is not known, you can repeat, but only after 2 years, that is after 24 months, not before that. That becomes useless, because you have to weigh what is the cost and what is the benefit and the risk ratio. So you have to weigh that. And of course, the thing that came out of the recommendations from the ATA, there's American Thyroid Association guidelines, they will tell you not just to intervene any patient with that, just like that. You intervene when there is definite indication for intervention. So nodules less than 1 centimeter and with very low suspicion, please do not go for any further sonographic follow-up. You do not need that. So more than 1 centimeter and very low suspicion after only 24 months, low to intermediate on ultrasound, you repeat that after 12 to 24 months, and highly suspicious nodules you can again do after 6 to 12 months. And what about the role of medical surgery for benign thyroid nodules? Of course, if you have a surgery, can be done for the nodules, for the growing nodules that are benign after repeat FNA, but more than 4 centimeters, causing compressive or structural symptoms, or based on the clinical concern, it is looking very odd for the patient and she's going to get married. So she is urgently requesting you that I don't need this nodule out there. It's actually cosmetically very bad. So then you can consider that one. So last 2 slides, we were talking about the summary of algorithm, whatever I have said. This is just to summarize them up. You get a nodule, you evaluate the patient by taking proper history, by doing a proper physical examination. Please don't forget the basic things which our teachers told us in our clinical classes. These are very, very important at every moment. You look for associated cervical lymphadenopathy. You also look for any history that might tell you that yes, that this patient might have a suspicious malignant lesion out there. So after doing that, you do a TSH, it's normal or it's elevated, then only you go for a thyroid next sonography. What do you see? You get a highly suspicious lesion or an intermediate, you go for an FNA. If it is more than or equal to 1 centimeter, of course, if it's a low suspicion pattern, then also you can go for a FNA if it's more than 1.5 centimeter. Very low suspicion, you can go for FNA, but of course you can just follow them up. And you do FNA only from the nodule which is more than or equal to 2 centimeter. Benign, you do not require an FNA. That's very, very important. And after doing an FNA, what can you get? You can get Bethesda, as per the Bethesda classification or the Thai classification, you can get a non-diagnostic. You have to repeat an FNA because that is non-diagnostic. Because those are the lesions which often harbor malignancy to the tune of 10 to 15%. You get a benign lesion, do not require surgery. Now, like I said, the problem starts when you have this problem. There is a ATP of undetermined significance or follicular lesion of undetermined significance, or you simply have a FN or a FSN, or you have a suspicious lesion. Then FN or FSN and suspicious lesions, they will go for land up into an excisional biopsy because they have to see, sometimes you get a foci of malignancy out there. And since these are the malignancy which can be treated easily and have very good outcome, this malignancy should not be missed because these are life-saving. And of course, if you get a malignant nodule, don't worry about that. You just have to go straight ahead with the surgery. And this is just to tell you about the molecular testing for the intermediate onward cytology for 3, 4, and 5, like I said. You can do all these stuffs, but like told you, I'll be sharing only the viewpoint of a physician like me, and I'm not an endocrinologist. So an endocrinologist will be the person when you get this kind of ATP or you get FN and FSN, please refer them to them because they will determine which are the patients that will require genetic testing and which are the patients which will not require the molecular testing. Because till now, molecular testing is not a general recommendation since we do not have a long-term data as per the ATA 2015 guidelines. So let them decide what they want to do. So thank you so much.
So thank you, Dr. Roy. It's really a very, very fantastic talk, and I enjoyed thoroughly. Really a nice overview of how to approach a thyroid nodule. So just to set the ball roll, there is no question. Dr. Roy.
Yes, sir.
Say, what is the cutoff when you do plan a thyroid nodule biopsy? What is the size where you definitely ask the patient for the biopsy, and at what level we ask there is no biopsy is not required?
So just like we said, that it depends on the if it is a highly suspicious nodule, we will go for a FNA if it's more than or equal to 1 centimeter, and if it's a low category lesion, then we can go for an FNA if it is more than 1.5 centimeter. But of course, we can go ahead with a very low suspicion lesion also, only and only if it is more than or equal to 2 centimeter. So these are the things when we go for an FNA, and then we, on getting the FNA report, we generally refer to you all, sir. That's because you have to now decide which with the who will the patients with like Bethesda 3 or 4, and what are the patients who will be requiring a biopsy. So, sir,
so very what Dr. Sykes Roy is telling, that is very clear. The nodule size, any nodule more than 1 centimeter actually requires the FNAC. At least that is one thing. If the suspicion is high, even lesser than 1 centimeter may also require a FNAC. That is one thing. And very important thing is, while approaching a thyroid nodule, the physician alone cannot do much actually. Say physician mainly diagnose that patient is having nodule, patient can reach to the physician. But the next step is to do a good ultrasound. So the role of sonologist is very, very important. And what I say to our physicians, that whenever they get an ultrasound for the thyroid gland, it should be by the specialized person. And ask them to write very clearly what is the, like for COVID, we are asking the stage corrects. Similarly, for the thyroid also, that is TIRADS. And very clear, without TIRADS, you cannot reach to any conclusion. So like TIRAD 1 and 2, that is usually benign, nothing to do that. But after TIRAD 3, definitely requires the FNAC or biopsy subsequent thing. So the sonologist plays a very, very important role. So now if you have decided that patient should undergo a FNAC, now the role comes who is doing FNAC. So that is also very important. And sometime when there is a situation is tricky, always suggested to have a ultrasound guided FNAC, so that you can target clearly which nodule is having more chances to a malignant kind of potential. Then you should take biopsy from FNA from there. And at least that FNAC should be 2 times, the tissue should be 2 times, that is important. And then it is preferred that by the side of FNAC room, there should be analysis area also. So that immediately they can see that enough material is there or not. They are able to give some conclusive remark on that or not. That is also very important. So that you can do that. And for that, there is a criteria, at least in one high power field, you should see at least 6 to 10 follicles. 6 to 10 follicles with 15 cells. That is a must to have the enough amount of FNAC tissue is there to comment on that. And Dr. Roy also mentioned something like that, what is the role of the FNAC tissue, and then you can do various genetic markers. But I think the current status is not very clear. Initially, people thought the RAS is very important, BRCA is important, but now it is not very clear. So there is long-term studies are required to reach to any conclusion on that part. So I think there is some few questions are there.
Yes.
So next question is, does it matter if there is a solitary versus multiple nodules? So Dr. Roy, yeah.
Yes, yes, sir. I think every nodule should be managed as per the same sequence, like I said. So every nodule will matter depending on the suspicious lesion as per the thyroid classification, just like Sir said now, and I also showed that in the from 0 to stage to +7, we have all the 7 classification on thyroids, and then we pick up which lesion should be intervened. And of course, if you get multiple lesions, we might require multiple biopsies from them.
Exactly. Very good answer, Dr. Roy. It is apt answer actually. And I'm just a little bit refining that every nodule should give thyroids for that. Every nodule requires thyroids. And according to the thyroids, if the thyroid is grade 3, every nodule should be by FNS, should be subjected for the FNS, so every adequate results. Other thing is that fortunately, these thyroid nodules are just 5 to 15% as malignant potential. Most of them are not having the malignant potential, so that is a good news. But they need the regular follow-up, and I may say that, as Dr. Roy told, that it requires the long-term follow-up. That is very important because anytime they may develop the malignancy, so they require the close follow-up. And very important thing, I think we should tell our patient, please keep all the records preserved.
Yes.
That is very important, especially with relation to the thyroid nodule, because patient will lose the old information and then you don't have anything to compare what was earlier and what was this. So it is always good, being a physician, if you have time, you can make a table yourself on the patient
That's
card.
what we do. That's what we do. Like,
Yeah.
this is the first initial findings, and after 1 year,
Yes.
after 1 year, yes.
Very good. So patient, if you don't have time, then at least now patients are very smart. Tell them you can make this nice Excel sheets every time you can discuss on that. So that is there. And I love the mnemonics, so that what Dr. Roy told is that there is you should know about the composition, shape, and the margin, the echogenicity, and internal echo. So that is formula you can call CSME, clinically significant macular edema. So these are the 5 points you can remember, CSME. So one is composition, second is your shape. So wider than taller is there is more risk. Then you can say margin, irregular margin is more risk, though they have also grading. Then echogenicity, hypoechoic, hyperechoic, isoechoic, and then internal echoes. So this is a formula physician can remember, CSME. So these are the 5 important points in the thyroids also.
Thank you, sir. Thank you so much. Thank you so much.
I think
for the question also, sir. Thank you.
Yeah. If there is no more question, I think I'll thank Dr. Roy for this wonderful presentation, and all the audience for their active participation. And I am handing over mic to the dais to organizers. Thank you very much for the opportunity to interact with this August gathering in this Sunday. Thank you.
Thank you. Good morning, everyone. I'm Dr. Monojit Ketan Mukhopadhyay. If you any of you don't know me, I'm the Joint Vice of the RCPI Indian chapter. I must congratulate Dr. Shayak Rai for his excellent talk, and Dr. Sanjay Barara for navigating the discussion, into the nitty-gritties of the thyroid nodule. And that's why we've chosen a young speaker with someone with experience who can actually help us to to navigate the nitty-gritties of the talk. So thank you very much for your time you've given us, and I would expect the audience to type in some questions in the chat box, as we would want more participation from the audience rather than having more discussion between the speaker and the chairperson. So with this, we move on to the can we have the next slide, please? The next topic is on diabetes, and it is a sponsored session by MSD. The topic is diabetes management, gender and age as key consideration. And the chairperson for this is Dr. Manoj Chadda, whose CV is on the screen. He needs no introduction. He's well known nationally and internationally. He's a very good friend of ours, and he's been an examiner for the clinics of the MRCB Part 2 examination for a long time. So over to you, Dr. Manoj Chadda, to start the ball rolling.
Thank you, Manojit. It's a pleasure to be with old friends after a pretty long gap. And after a very interesting, informative talk, we go on to the next talk. May I have Sagarika's slide for introduction? Yeah, I think she's your local specialist, and she's a physician, consultant, and endocrinologist. Special interest in thyroid disorders, lipid disorders, and pregnancy and diabetes. So it seems to be a very hot topic. She's a visiting consultant at Columbia Asia Hospital, Kolkata. And she's been trained in UK in endocrinology and medicine, numerous publications, is a active member with the Royal College of Physicians of India, the Indian chapter, and also an examiner at the MRCP Part 1 and 2. And she's been a teacher and facilitator for the PHFI courses on diabetes. Sagarika is going to talk to us about the management of diabetes, probably with a focus on DPP-4 inhibitors in relation to gender and age. I'll hand over the proceedings to Sagarika, and probably we can have a discussion after she has given us her presentation.
Can I share my slides now? Thank you very much, the organizers, the Royal College of Physicians of Ireland, the Indian chapter, for asking me to come and talk. And my heartfelt thanks to my sponsors, Mark Shop and Dome. And it will be injustice if I don't thank Debashish for providing the seamless technical support that we have, not only for today, but for our everyday proceedings. Thank you very much, Debashish. So I'll be talking, my focus of my talk will be mainly about gender, and also there was a mention about age. But since in all of the diabetes forums, we tend to talk about age a lot, I shall try and focus my talk on gender because we are bound with time. So if I go on to talk about age and gender, that's really going to take up a lot of time. So there are two aspects of challenge, how men and women are different. Male and female diabetics differ physiologically, as well as there are some psychological differences as well. Not only this, there are some social biases as well, such as, for example, in a family, many of the families really, in an Indian background or a South Asian background, the male persons with diabetes are treated a bit differently than the females. Male person get diagnosed with diabetes, gets a lot of attention regarding his diet, regarding procurement of medicine, and it's been seen, especially for homemaker females, that medicines are not given on time, meals are not on time, they tend to eat after the male members have eaten, they do not really pay so much of heed as to how to really look after them, and as a result of them, because of the poor management of diabetes for a lifelong, for entire life, really we see them that they're in shambles towards the end part of their life. Not only this, there are also some biases in the guidelines that we tend to follow, or from the large scale epidemiological studies from where the guidelines of diabetes are drawn in. There are some biases in this as well, which I will be focusing on. So what is the lifelong impact on gender and diabetes? As we all know, that definitely there are some biological and social factors which tend to affect fetal programming of the newborn, and that has an effect on development of metabolic disorders and type 2 diabetes. Not only this, sex hormones also have different effects on the behavior of male and female during their entire lifespan, and some physical changes that tend to happen in male and female. And of course, chronic diseases like diabetes, heart disease, cardiovascular disorder, etc., are influenced by a combination of biological and social factors. If you notice the diabetes map of the world globally, the pink map is for the women and the blue map is for men. There is not much difference in the dark pink and the dark blue colors, which tend to indicate the highest prevalence of diabetes in these global regions. There is not much difference in the dark pink and the dark blue regions. More or less distribution of diabetes globally between men and women are more or less same. But it's said that when you talk about obesity, women are more obese at a given age than men, especially women start with obesity quite an early age than men. If you notice the physiological difference between men and women, there are some difference in the HPA axis, some difference in insulin sensitivity, amount of fat content of the body, the distribution of fat in the subcutaneous tissue and the visceral tissue, the amount of muscle mass. Men contain a lot of extra muscle mass than women, the action of adiponectin and leptin, which also tends to play a role in development of diabetes. And when you look at, translate this in pathophysiology, what says is that men tend to suffer more from impaired fasting glucose tolerance, whereas women have more impaired glucose tolerance. And also there is this thing for polycystic ovarian syndrome and development of gestational diabetes, which tends to affect further development of diabetes. Also, men and women react differently to depression. There are different degrees of presence of fatty liver, and androgen hormones actually play quite different role both in men and women for development of metabolic problems and diabetes. So it's rightly said that men are from Mars and women are from Venus, because women contain, the main difference, the differential factors are women contain a greater amount of fat, greater distribution of peripheral fatty tissue, less amount of water content in the body, high heart rate, low average blood flow into the organs, low GFR, low GI mobility, gastric emptying, etc., which all tends to affect the metabolic problems. So let's look at the diabetes risk factors. BMI again is a very strong indicator of obesity and development of metabolic problems. Rather than waist to hip ratio, if you calculate the waist to calf ratio, which interprets the better predictor for development of type 2 diabetes in women. What about clustering of metabolic factors? Now, metabolic risk factors, or the METES syndrome, which tends to happen quite a number of years before development of diabetes, which is associated with obesity, increased waist hip ratio, association with hypertension, etc. We see that there is high prevalence of hypertension, an increased amount of fatty tissue in women, and also the combination of the typical dyslipidemia, that is high triglyceride, low HDL, high LDL level with increased waist to calf ratio is most prevalent in women, particularly in young females. Also, physical activity, the reaction of physical activity has got a greater impact on obesity and is more closely associated with abdominal adiposity in women, and there is no leisure time physical activity at all. And of course, impaired glucose tolerance is more prevalent in women, but men have more fasting glucose intolerance, that is raised fasting blood sugar. Shift work tends to affect women more than men. Job strain, on top of that, there is strain of homemaking as well, tends to affect women more. Low socioeconomic conditions, low education has got a worse impact on development of metabolic problems. And of course, smoking is there for men and women. Patients being treated for diabetes, now impaired glucose tolerance is more frequent in women regardless of ethnicity. It's present in Caucasians as well as in Southeast Asians as well as Afro-Caribbeans. Insulin sensitivity in women in general is lower than the men. This could be accounted for the fat distribution that the women have. And with age, with age, there is gender differences, which tends to come in, really becomes more prominent and leading to more pronounced worsening of metabolic profile in women than in men. Now, if you look at the other parameters, like gastric emptying is a bit slower in women, so therefore absorption of carbohydrate is much greater in women than in men. So therefore post-meal excursion of blood sugar levels is much higher in women than in men. Increasing body fat with lower resting energy expenditure reduces your insulin sensitivity in women, and with women with type 2 diabetes or metabolic problems have lower GLP-1 response to oral glucose challenge than with normal glucose challenge. So patients who are treated for diabetes, more or less we see when a woman gets diagnosed with diabetes, they may carry more comorbidities like hypertension, pre-existing heart disease, etc. Physical limitation is of course there because the physical strength by nature, women have lesser physical strength. There is higher prevalence of depression due to really several reasons. It could be related to your family matters, related to job satisfaction, related to overwork, and women tends to react to more to anxiety, depression, and all these factors. What we also see is that nephropathy tends to have women have higher proteinuria and renal disease, but when in terms of chronic renal failure or in terms of renal failure moving into dialysis, men undergo dialysis more than women. Coronary heart disease, men and women have equal degree of coronary heart disease, particularly post-menopause, and mortality in women with diabetes is slightly higher than in men. Vascular risk was particularly higher in younger subjects and among women. Dialysis, again, dialysis mortality on dialysis is worse in women than in men, and pregnancy complication associated with diabetes or with gestational diabetes, of course, is higher in women. Men do not have all these things, and they tend to suffer from preeclampsia, hypertension, and all these have their after effect on the later on in life. Not only this also tends to have an effect on development of diabetes or metabolic problem for the baby as well. We have a poll question here. I don't know whether we have any thing to answer this poll. Which between the two below is a better predictor for type 2 diabetes in women? Is it the body mass index, the waist circumference? Neither. Equally, both are good predictors. I think both the body mass index as well as the waist circumference. The waist circumference gives you a better idea of the amount of fat content of the body than the BMI alone. So waist circumference is a better predictor, particularly for women, for giving an idea of metabolic problems and development of diabetes. There is also a high prevalence of diabetes as age increases, high prevalence of hypertension in women, which is again a part of your metabolic syndrome as well. And gestational diabetes, if a woman has gestational diabetes, you have to look out for gestational diabetes now. Our understanding of gestational diabetes is changing as more and more women get diagnosed with gestational diabetes, maybe because we have our more inclination to testing women for gestational diabetes. And it's said that because in Southeast Asia, we have got a high prevalence of diabetes, women at the time of booking for pregnancy, at the time of the booking test, they better get a baseline blood sugar test done so that gestational diabetes gets diagnosed quite early rather than leaving it up to the second trimester, which is the textbook saying. So once your hyperglycemia get diagnosed quite early in the pregnancy, you can treat accordingly by manipulating their diet and starting them on medication, as well as if required, start them on insulin. But it must be really educated to these females that there is high chance of developing type 2 diabetes later on in the future. And if not in every year, they should be testing for prevalence, increasing prevalence of high blood sugar levels. And if at all type 2 diabetes get detected, they should be treated early. Polycystic ovarian syndrome, as our socioeconomic condition is changing, physical inactivity is increasing, food intake, the type of food that we take is changing, that we tend to consume a lot of amount of high energy containing food. Obesity is increasing in teenage and young girls, and polycystic ovarian syndrome is on the rise. And as we all know that polycystic ovarian syndrome is also a part of the metabolic spectrum, increases with insulin resistance, and there is a high chance of these women developing gestational diabetes as well as having type 2 diabetes in the future. So women suffering from polycystic ovarian syndrome, whether it's lean, which is 15% of PCOS, or obese, of course, will have to be screened for early for development of diabetes. Now, postmenopausal women, incidence of diabetes in postmenopausal women is on the rise and equal to that of men, because there is obviously the loss of estrogen protection in postmenopausal women. Body composition changes, there is increasing amount of insulin resistance, increasing amount of fat in the body, insulin sensitivity gets altered, and diabetes develops. So we have a second poll question here. MI and symptoms of depression are more common in the women. Yes. Men experience more severe hypoglycemia and nocturnal hypoglycemia than women. Women end up getting treated more aggressively than men, all of the above. Which is the true? I think the first one, MI and symptoms of depression are more common in women. The other statements are really not true. Let's look at the adipokines. Amongst the adipokines, the adiponectin and leptin, which are closely associated with metabolic disorders. Leptin is one of those hormones which plays a big role in regulation of satiety, food intake, energy expenditure, and also influences the insulin-glucose axis and peripheral insulin resistance. And adiponectin is involved in lipid and glucose metabolism and increases insulin sensitivity in the target organs. And there is dysregulation of adiponectin and the leptin balance can lead to development of type 2 diabetes. Women in general show an upregulation of the expression of adiponectin and its receptor in abdominal adipose tissue, possibly contributing to the low cardiometabolic risk. And women with higher leptin and adiponectin levels than men in comparable age and BMI, which is really related because of their sexual hormones. There are certain novel biomarkers like hepatokine fettuin A, which is related to type 2 diabetes in women only, copeptin, which is the C-terminal portion of precursor of vasopressin and marker of arginine vasopressin secretion, also associated with risk of future diabetes, and increased liver enzymes indicating development of insulin resistance, fatty liver disease, insulin sensitivity is directly related to development of diabetes. Now, pre-diabetes also categorically differs in men and women, as I have iterated before, that men tend to suffer more from impaired fasting glucose, whereas women tend to have more glucose intolerance. Gestational diabetes, more than 70% higher incidence of diabetes than pre-diabetic women. Even normal weight women are also susceptible to develop gestational diabetes, and you have to be particularly cautious if the woman has polycystic ovarian syndrome in the past, that you have to look out for gestational diabetes. Women are more prone to psychological factors and adverse effects of cardiometabolic impacts on psychological stress, occupational stress, sleep disturbances. There is a lot of impact about unpaid housework, excessive pressure at home, and women who are working has to really keep up a balance at work to be proven that they can be equal to their male counterpart at place of work, as well as do all the household work and have the household responsibility that really has quite a greater impact on the metabolic problems that the woman has to face. What about the fetal sex and the risk of gestational diabetes? Yes, there is some inclination on the fetal sex as well. A woman carrying a boy in the first pregnancy have about 3 to 4% higher risk of gestational diabetes, whereas they carry a boy in the second pregnancy. Carrying a girl in the first pregnancy, you can actually maintain a normal glucose tolerance. And when a woman is carrying a female fetus and then a male fetus, they had increased beta cell capacity and higher postprandial glucose level during the glucose challenge. And this might be related to the Y chromosome of the fetus. What about the evidence of generation? Are the women specifically studied and reported? Now, all of the guidelines that we tend to follow for diabetes, which shapes the treatment, what we deliver to our patients. Now, if you follow all of these guidelines, and if you follow the studies from where all these guidelines have developed, be it the UKPDS, be it DCCT trials, or even the recent most, the cardiovascular trials, or Accord Advance, and all these trials, the women representation is quite significantly lower than the male representation. Either the collaborators were not mindful, or participation were not up to the full, or the registry from where women were recruited were not adequately maintained. But in general, males are better represented in all of the landmark trials that we tend to see, be it diabetes, cardiovascular disease, or whatever disease, unless we are really specifically looking at women issues like gestational diabetes or polycystic ovarian syndrome. Large-scale trials more or less represent men. What about risk of fracture in the treatment of diabetes? There is not much difference in treatment of diabetes with metformin to start off with, DPP-4 inhibitor, SGLT2 inhibitor. But however, women with advancing age, particularly after menopause, have an increased risk of having fractures and osteoporosis. So when you're choosing your medication, then you have to be a bit mindful whether the medicine has an increased propensity to increase osteoporosis, like glitazone, specifically pioglitazone. You have to be a bit mindful when you're giving pioglitazone to a postmenopausal woman. It's been seen that many of the studies, especially with DPP-4 inhibitor sitagliptin in postmenopausal women, that it does not really increase your fracture risk, and the fracture risk with sitagliptin was equivalent to that of placebo. Effect on bone metabolism of sitagliptin is likely mediated predominantly through the bone resorption rather than bone formation. There was no increased risk of fractures or increased risk of osteoporosis. It's also been seen that polycystic ovarian syndrome, metformin is the mainstay of treatment. Why metformin? Because metformin influences your insulin resistance to the fullest. But there are women, because of metformin GI intolerance, you may not be able to tolerate the full dose of metformin. In those women, there is small studies, anecdotal studies, which has been done with sitagliptin, showing that these women who are intolerant on metformin, and if they're obese, given polycystic ovarian syndrome, can actually reduce their insulin resistance. So when you think about gender as a key consideration for a diabetic patient, you have to first and foremost think about empowering and educating the patient, counseling for better monitoring of the patient, screen the person, especially if they have polycystic ovarian syndrome or history of gestational diabetes, avoid polypharmacy so that they can take their medication on time, and you need really special monitoring, especially with metformin and litazone and insulin, also seeing that monitoring is properly done, meals are properly dispensed, and they are properly cared for. That's the end of my talk. Thank you very much for listening.
Oh.
I hope I was on time.
Yes, thank you. Yeah, that's why I just said I'll give you that last one or two slides. Thank you. That was a really extensive review on the gender differences. I think most of the talk in terms of psychological disturbances is very clear. In terms of the physical differences that you brought out was very interesting. And I hope the further landmark trials that keep this in mind. Although of late they have started seeing that there's equal representation.
Roughly about 30 to 40% female representation, but the bulk is male representation.
That's true. Maybe there are other social reasons for that. So the first thing that I found very interesting before I take up questions from the audience was the waist to calf ratio versus the waist to hip ratio. Can you tell us a little more about that?
Waist to hip ratio, yes, the waist to hip ratio might be quite subtle, but if when you calculate the calf, that actually represents your muscle bulk. Now, what does muscle do? Muscle also influences your insulin sensitivity. But fat also influences your insulin sensitivity. But if you have a good muscle bulk in your calf, and if that is compared to the amount, your waist can actually interpret the amount of insulin sensitivity you have and the development of future metabolic problems. Whereas waist to hip ratio really gives you an idea about the amount of fat content of the body, doesn't tell you about insulin sensitivity that you have.
And you mentioned about the delayed absorption in the females as compared to males. Is that I understood correctly?
Delayed
absorption.
There is delayed gastric emptying. There is delayed gastric emptying, and therefore your nutrients tend to stay in the gut for a longer period of time, and that can contribute to your higher postprandial blood sugar levels.
No, but it could be the other way around also, because delayed gastric emptying means it's reaching the small intestine slowly.
Yeah, you can interpret in that way.
Because then that's what we try to do with one of the actions of GLP-1 analogs is to delay the gastric emptying, so cut down on the postprandial peaks. So you mentioned a couple of, I think, references with sitagliptin and advantages on the bone. So if I were to ask you, there is a, let's say, a 55 or 60-year-old lady newly diagnosed diabetic, what would be your choice of oral anti-diabetics in such a patient?
Of course, metformin, which is the first line, along with diet and lifestyle management. And on your second line of management, depending upon at what level of A1C you find your patient,
We seem to have lost Sagorika. In the meantime, if there are any more questions from the participants or the faculty, we'll be happy to take those questions up.
Other thing is urinary tract infection is much more common in the women. In fact, this is one of the most common cause of hospitalization of women. Maybe that is another important thing.
Especially when we are talking of postmenopausal. You see, postmenopausal women are a very interesting category when we are talking in terms of bone osteoporosis.
Yeah.
We're talking in terms of infection, Even there, I mean, between males and females, probably the body mass composition also changes considerably.
Yes, yes, yeah. During that immediate postmenopausal period. So that's
Yeah,
there.
that is interesting.
Maybe choice of OAD is another important thing. We can avoid pioglitazone, may
Yeah.
prefer DPP-4 inhibitors, or may prefer the GLP-1 receptor analogs, because the coronary, it prevents the coronary as well. It is good for the bone health also. Now the data that osteoblastic effect is very good on the with the GLP-1 receptor analogs. So now people are trying to use that more frequently in the women, in view of their weight as well as cardiovascular as well as the bone health. Yeah.
I think, Sanjay, you made a good point. I want to re-stress it that pioglitazone or the glitazone family should be avoided in postmenopausal women because it diverts the mesenchymal cells more towards the adipocyte lineage and takes it away from the osteoblast lineage. And that's why, so this effect has not been seen significantly in males, but in females for sure. And yeah, this is a good point. Probably the GLP-1, the incretin axis is important also in maintaining bone. So that becomes another factor in deciding the choice of anti-diabetics in women.
Yes.
Okay.
Sir, also, I think that once we are using SGLT2 inhibitors along with pioglitazone, we have to be a bit careful because of this bone health. If there is
Sagorika, I think she's back now.
okay, yes, Madam.
I don't know why I got disconnected.
Yeah, that's what. So we were talking behind your back. Okay. Probably we have run out of time. So if there is any other question, otherwise I'm going to hand you back. Or you want to make a last statement?
Yes, you were asking about a woman, 60-year-old, getting diagnosed with diabetes, what to start off with. Of course, diet, lifestyle, and metformin. And on the second line, depending upon what level of A1C you start, say, for example, 7%, you may jolly well start with a DPP-4 inhibitor or an SGLT2 inhibitor if the renal function is preserved. Or if it is something around, say, 8.5 or 9, may give a sulfonylurea with caution.
Yeah, and you also made some difference in terms of insulin response. Again, is that probably related to the adiposity, or you mentioned about the difference in sensitivity also?
Yes, there is a difference in adiposity. Women may require a higher amount of insulin with comparable BMI of men because high content of fat and low muscle mass, which influences insulin sensitivity.
Okay, thanks, Sagorika. That is an
Manoj, there's one question from Dr. Devmalla Sanyal.
No,
Q&A.
Okay. So increased diabetes in the same family. I mean, between the stress, probably he's asking about the stress response between the same in the same family between males and females. And is there any glycemic variability that has been described during the menstrual periods?
Really not. I haven't looked up on the literature. This is something very interesting to be looked upon in the literature, whether there is any glycemic variability during the menstrual period. If you think about scientifically, yes, during the menstrual period, there is increased amount of stress and that can influence glycemic variability. But again, women tend to carry on their normal day-to-day activities, about working outside, working at home, managing the same thing. So this is something really to be looked upon.
Yeah, I think I would agree with you on this, that theoretically there is a possibility, but like you said, they are the stronger sex. So they probably get over these as a part of life and move on. Okay, thank you very much, Sagorika. And I'm going to hand you back to you.
Okay, thank you very much, Dr. Manoj Chadda and Dr. Sagorika Mukherjee for their talk and their discussion. So we want to move on to the third session today.
So, I have another question in the chat box, sir.
Another question coming in late. Okay, Manoj, sorry, just last one question for you.
No, it's not connected with her talk. MODY is not connected with really this talk. So let's separately.
Okay, thank you. So we move on to the next topic, which is on infectious diseases and respiratory illness, management of respiratory failure in patients suffering from COVID-19. For this talk, we've chosen two physicians right from the epicenter of the COVID pandemic from New Delhi. Our chairperson is Dr. Dinesh Jain, who we know very well. He's very close to us. He's the liaison with the RCPI and the Indian chapter and the Medical Council for India for getting us the recognition. And he's been also an examiner for several years, and he's very, very close to us. And the other one is a frontline worker on COVID-19, Dr. Ranajit Chatterjee, who's been managing COVID patients, and he was so committed that actually he was afflicted with the disease and came through it with flying colors. As now he's back to work, and he's given his hospital rounds and he's in his hospital dress, and he's going to address us on that. So over to Dr. Dinesh Jain to carry on with the remaining part of the talk.
Good afternoon and greetings to all the distinguished ladies and gentlemen of the medical fraternity participating in this first webinar of the Royal College of Physicians of India, Indian chapter. As I speak this very moment, we continue to be in the accelerating grip of the COVID-19 pandemic. Sadly, we are now racing ahead to surpass all countries in the number of cases and deaths. The symptomatology of COVID-19 is wide-ranging and bizarre, from pulmonary manifestations to stroke, to cardiac events, to skin rashes, to just general weakness and tiredness. This virus has foxed and puzzled the medical world to no end. Our understanding of the diagnosis, pathophysiology, and management of COVID-19 is still limited and mercurial, changing on a daily basis, with a bombardment of constantly evolving protocols and guidelines, both diagnostic and therapeutic. From all over the world, we are left to fend for ourselves when it comes to diagnosing and managing a COVID-19 patient in our clinical as well as hospital settings. With an overwhelmed health infrastructure and the facilities, and no definite treatment yet, and a couple of vaccines in the pipeline, we have no option but to face the malignant wrath of COVID-19 with a limited arsenal. The real challenge for us is protecting ourselves first and then managing COVID-19 to the best of our ability, judiciously and effectively. This is easier said than done. And to throw light on the management of respiratory failure in patients suffering from COVID-19, we have with us today Dr. Ranajit Chatterjee, who has the first-hand experience of managing such patients in the ICU setting. Dr. Chatterjee qualified the MBBS from the Calcutta University, then did his post-graduation in anesthesiology from the Aligarh Muslim University. Thereafter, he did his post-graduation in medicine by qualifying the ICRCPI exam of the Royal College of Physicians. And in addition, he did PG training in intensive care from the All India Institute of Medical Sciences in New Delhi. He has also done advanced resuscitation training from the Southend General Hospital in the UK. At present, he is in charge of the intensive care and accident and emergency department at Delhi's very busy Swami Dayanand Hospital. Now I call upon Dr. Ranajit Chatterjee to enlighten us on this very important problem of respiratory failure in COVID-19. He will speak to us for 20 minutes, and then we have 10 minutes for question and answers. Audience are invited to post their brief questions in the chat box. I now hand over the screen to Dr. Chatterjee. Dr. Chatterjee, please.
Thank you so much, sir. First of all, you have already introduced COVID like anything with your emotional speech. And I just want to, first of all, share my gratitude to the Royal College of Physicians of India, Indian chapter, Dr. Sabyasachi Ray, Dr. Manojit Mukhopadhyay, Dr. Sujay Majumdar, and obviously Dr. Jain, who has bestowed upon me this opportunity to speak on one of the most important topics today, which we can't think of anything else except for COVID nowadays. So I think I'm audible, and the screen is also shared well. Thank you. So first of all, I salute to those heroes all over the world, and especially of India, where lots and lots of healthcare workers have died. More than 600 healthcare workers have died. 200 doctors have led their lives, and more than 1 lakh has been involved in this pandemic. And I don't know how many all over the world. I myself was involved, whole of my family, we are fortunate to come out of it. and we have again jumped into the arena to serve these patients. I have basically lost the counting. See, in the world, around 29 million, 9 lakh deaths. India is racing ahead. 4.7 million cases, 77,000 deaths. And today, ICMR has told that we are missing around 80 to 130 cases for one case. I don't know how many cases we are having in India. Our Ireland counterparts are in a better position. They have only 30,000 cases with only 1781 deaths, and they are in 69th position in the list of countries who are suffering from this pandemic. So let me start the journey very quickly. See, here the journey starts. When the virus enters us through our nasopharynx, it directly goes to the lungs. And in the lungs, it attaches to the S2E receptors. The maximum concentration of the S2 receptors are there in the lungs. And the spike protein of the virus attaches to the S2 receptors, enters the epithelial cells, virus is released, and it also gets vacuolated inside the macrophages, and from there it migrates. It migrates to all the organs which are having SE2 inhibitors, the SE2 receptors. They are the blood vessels, they are the heart, it is the muscles, it is the pancreas, our gastrointestinal tract, our brain, kidneys, everywhere. And we get the symptoms. If you start from neuropsychiatric symptoms and encephalitis in the brain, we have acute kidney injury in the kidneys, we have complete heart block and different type of blocks from the heart, we have myocarditis, we have diarrhea is one of the symptoms that, and we developed acute loss of blood sugar control, acute diabetes. The liver enzymes are enlarged. So in this way, the multiple organs will be involved if we are unlucky. So today we are going specifically to discuss about the lungs because it is the most common organ involved and most of the patients are suffering and dying from the disorders and from the problems that are occurring to the lungs. So this is pathophysiology of CARDS. CARD means COVID-induced ARDS, that's acute respiratory distress syndrome. So there are three pillars here: hypoxemic respiratory failure, cytokine storm, and the COVID-19 related hypercoagulability. So once the virus enters inside it and it gets accumulating inside the alveolar epithelial cells, slowly the alveoli get filled up with the fluid and you have a blood supply, but you don't have any ventilation. So there is increased shunt. This is one of the pathophysiology. On the other hand, when you are having a lot of microthrombi in the capillaries are getting blocked, your alveoli is fine, maybe, so you have an increased dead space. So you don't know exactly where you are, whether you are having an increased shunt or an increased dead space, you are lost in between basically. And on the basis of this, we have broadly divided the problem into the L phenotype and an H phenotype. H phenotype is the type where the alveoli predominantly are involved, where there is a high right to left shunt, where the alveoli is involved, so there is a low pop length and a high elastance. And these are the patients which respond to higher positive end respiratory pressure. Whereas the L phenotype, the happy hypoxia type, where you will have the microthrombi deposited in the capillaries. So endothelium, capillary endothelium is involved, but the alveoli are spared. So you are in a happy state as if, but your hypoxia is continuing. The compliance is high. This is the case where you don't have to give much amount of high positive end respiratory pressure to the patient. So these are the two phenotypes. Most of the patients, they move to the H phenotype very quickly from the L phenotype ultimately. But we have patients with those L phenotypes who are roaming around in the maybe in the community, never knowing that they are having that amount of problem with them. So the second step is the cytokine storm. What happens once the macrophages in the dendritic state starts releasing the cytokine signals, there is an inflammatory reaction, and the lymphocytes, they start gulping the gulping the virus, and the lymphocytes gets destroyed. So there is lymphocytopenia. Once the lymphocytes gets destroyed, they release a lot amount of cytokines, and once they release a lot amount of cytokines, what happens? You have the cytokine storm all over inside you, and you see that is the time when you measure the neutrophil lymphocyte ratio, the C-reactive proteins, the ferritin, the LDH, the IL-6, the procalcitonin. These, all of these except the procalcitonin are rising here. These are the signs of cytokine storm. And if the organs are involved, you will see the changes in the bilirubin, SGLT, urea, creatinine, trophi. That means your organs have also started getting involved. And the third one is the coagulopathy. Once there is endothelial cell dysfunction, inflammation starts, there is cytokine storm, you have microthrombi all over. And that is represented by the D dimer. Once the D dimer starts rising, that means your coagulopathy has started. It may go into an overt coagulopathy when the prothrombin platelets and fibrinogen are getting involved. That is when there is a rise in the prothrombin, decrease in the platelets, increase in the fibrinogen level. That means you are going into an overt DIC type of state. But normally patients are restricted here, and we have to basically do all these tests along with the pathophysiology. I'm showing you exactly how to manage your patients. So with the D dimer, you can understand the coagulopathy. With all these tests, neutrophil lymphocyte ratio, if it is going above 5.5, if the CRP is going above 125, the ferritin is going above 800, the LDH is going above 500, the IL-6 going above 80. This is the situation of a severe type of the infection. Similarly, when you are in hypoxemic respiratory failure, you may be an asymptomatic or a mild case where the SpO2 is more than 94, your respiratory rate is less than 24. But once you enter this moderate phase, you have to be very cautious. The SpO2 is just coming down, the respiratory rate just going up. You are in a stage of denial. No, I am all right. But that is the stage when you have to basically interfere so that you don't go into the severe stage where the SpO2 is coming down to below 90. You have a high respiratory rate, high demand, and the PO2 ratio has gone down below 100. And you have nothing to do but to end up in a critical stage of ARDS and septic shock. So when the patients will come with, as you all know, with fever, cough, myalgia, fatigue, diarrhea, anosmia, that is dysgeusia. The interesting fact is that patients who are coming with fever and anosmia, we have seen that these patients are not landing up into serious crisis. And those patients who are having diarrhea, all of the family members are involved. These are the two important clinical presentations that we have seen. And myalgia is continuing for months. And when the patient may be absolutely all right, but you have a characteristic lung crepitation over your basis. If you are treating the patients, you'll definitely get this, even the patient is asymptomatic. And ARDS is present in 17 to 41% of the patients, though many of them remain undiagnosed because we are not going to do CT scan in all the patients. And average, they develop in the 8 days. And the average time of severity and death, that is the median time, is only 14 days. And so the 8 to the 14 days is the crucial time when every physician, every clinician treating these COVID patients should be very sincere about it. Now, after you have come with these clinical features, you send your patient for your diagnosis. The antigen test should be confirmed with the help of RT-PCR. Even the antigen comes negative in those who are symptomatic, you have to go for the RT-PCR test. You have confirmed this is the case of COVID. You have these 3 things in your hand. You have a chest X-ray, you have a CT scan, you have a lung USG. Now, chest X-ray, if your patient is there in the ICU, if the chest X-ray and lung USG can be done very easily. It is very difficult to do a CT scan once your patient lands up in the ICU. So in the chest X-ray, you have patchy ground glass opacities, mainly the lower lobe involved, multiple opacities, and they're bilateral, and they're in the peripheral predominance. If you get this type of chest X-ray, here like this one, the second one, you see you have a lower lobe involvement, and they're in the peripheries. Whereas this is the CT scan picture. These are the GGOs, typical rounded GGOs. This is a typical happy hypoxia type of CT scan. Whereas with this one, the second one, you will find there are many crazy paving patterns. The intralobular lines, you can see small lines that are coming up. These are the crazy paving patterns. Mainly they are found in the periphery. See, the GGOs are in the peripheries. This consolidation is the periphery. And sometimes you also have a hollow and a reverse hollow type of presentation. But the most important thing is the lung ultrasound. By bedside lung ultrasound has gone a long way in diagnosing these COVID patients and also in helping in many things that I'm coming now. Just see, you have to find these B lines. You can see the straight lines. These are known as the B lines, which are star marked. And this is the pleural line. This is the pleural. And if this distance is around 7 millimeter, that means you have interstitial edema. If this distance are less, is coalescing together, you are going into alveolar edema. So, and the ultrasound, this is the A lines, and there are parallel lines to this pleural line. This is the pleural line, and parallel lines to the pleural line are the A lines. This is the normal line. Whereas these are the B lines. That means your patient is affected. Normally, we divide each lung into 6 segments and we will give a scoring to this. Similarly, this is the pleural line, and you can see the small consolidations are coming, subpleural consolidations. And this white beam is coming down, and there's a black shadow between these white beams. This is a typical of a COVID ARDS patient, and this is a type of acute cardiogenic pulmonary edema, where you have a total whitish, no black lines, and this pleural line is more or less clear. There is no subpleural consolidation. Similarly, this pleural line is irregular. That's a pleural line is not altered in acute pulmonary edema. So if I show you this video, if you can see, this is one of my patients. See the B lines here. You can see the B lines here. Again, I show you the vertical lines coming down, and these are basically typical of ARDS and especially in COVID patients. ARDS, this ultrasound is really helpful by the bedside. See, you can diagnose the DVT from here, because most of your patients might lined up at DVT in the initial stages. You have to start that time your low molecular weight heparins. And if you are having increased D-dimer, along with this type of left right ventricular dilatation, see the D-shaped heart here. Normally it is rounded. And in the short parasternal axis view, if you have a D-shaped heart with a raised D-dimer and your patient is on ventilator and all the plateau pressures and the peak pressures, everything is normal. But the blood pressure is going down, the pulse rate is going up. What has happened? This is a typical case of pulmonary embolism. You can't diagnose the patient and carry the patient to your CT scan and can you do a HRCT chest or a spiral CT that time? It's very difficult. But the bedside diagnosis can be done with the help of this ultrasound. So ultrasound goes a long way in diagnosing and treating patients in the ICU. So I just a glimpse of it. Now see how rapidly these things has changed. From day 1, it was more or less clear. See the day 2 and the day 3, what has happened to this patient? Devastating. By day 4, this patient has died. So this is the way this progress is going on. We don't know exactly, as Dr. Jain has said, we exactly don't know what is going to happen to all the patients. So see, we can also diagnose pneumothorax. I'm not going to the details of this. Now see. So your incubation period is a median of 5.2 days. From here, you are going to become symptomatic. And you start with fever, malaise, cough, and you start all the drugs, hydroxychloroquine, vitamin C, zinc, ivermectin, maybe antivirals. But by the 11th day, when you are entering this early pulmonary phase, the SOB, the shortness of breath is coming up. Mild hypoxia is this. And this is the time when you have to gear yourself up. You have to start your anti-inflammatory. Read here dexamethasone in place of methylprednisolone. I use dexamethasone nowadays. The recovery trial has shown that 6 milligram per kg of 6 milligram of dexamethasone per day definitely improves the survival by 33% and by 1/3 in ventilated patients and 1/5 in non-ventilated patients. A DEXA-ARDS trial has come. It has shown that if you give a high dose dexamethasone, 20 milligram IV for the 5 days, and then 10 milligram IV for the next 5 days, you don't have to taper it off because it is a long-acting drug. Moreover, it has no intrinsic mineralocorticoid activity, so you are not accumulating fluid as opposed to methylprednisolone. And it is 5 times more potent than methylprednisolone. So use dexamethasone, start dexamethasone here when your saturation is just coming down. You have to see your D-dimer level and start on enoxaparin here. You may give antiviral in the form of remdesivir and plasma maybe in the moderate situation. And if you land up in the late pulmonary phase, in the cytokine storm with a high level of IL-6, LDH, neutrophil lymphocyte ratio going up, CRP going up, this is the time you start tocilizumab. There are studies in favor, against of all these drugs. But I am not discussed today about the oxygenation strategy. So once your patient comes up with the saturation coming down below 94, you just have to admit this patient and give some oxygen. Nasal cannula gives you around 4 liters, 4 to 6 liters. And the saturation and the FiO2 that you give, the saturation of the percentage of oxygen that you can give to the patient, hardly 40%. So from there we move to the face mask. From there we move, if the patient is still not tolerating the respiratory rate going up, we go to the non-rebreathing valves. We need to give this face mask give up to 10 liters. Non-rebreathing valves face mask give around 15 liters, and still the patient is hyperventilating, generating lot amount of tidal volume. We don't want that. We don't want that. We go and move to high flow nasal cannula. It gives around 60 liters. And if you are again failing with high flow nasal cannula, we go to NIV, non-invasive ventilation. If you're failing non-invasive ventilation, you go to mechanical ventilation. If you're failing that, we move to ECOT, that is extracorporeal CO2 removal, or to ECMO. The main aim is to avoid this patient self-induced lung injury, PCL. We have already been devastated by the virus, and we don't want addition of a patient self-induced lung injury here. So that is the reason we have to frequently change our oxygenation strategy, so that we don't want this patient to go into a situation where he hyperventilates, generates a lot of tidal volume. He wants that amount of flow, but we are not giving it to that. So that is the thing that we have to do. Now, one thing you have to do at all level is proning the patient. So we prone the patient for around 2 hours, then change it to the right lateral recumbent position for half an hour, then he is sitting upright for 60 to 90 degrees for half an hour, and again left lateral position for half an hour. In this way, move on, especially when the patient is in a non-invasive ventilation or in an HNFC. Very easy to do a prone positioning. It basically improves your VQ mismatch, reduce the shunt and the lung compression, recruits posterior lung segments, and improves secretion clearance. See, this is the helmet which is being used. You can, even with the prone position, with the helmet on, you can prone the patients very well. So proning has to be done universally in every patient who are suffering from this type of respiratory failure. High flow nasal cannula oxygenation, it's basically backs the patient's respiratory demand, because you are demanding a lot of flow which your face mask can provide you. So you can give up to 60 liters of flow here. So it reduces the work of breathing. It also, there's a pharyngeal dead space is washed out with this high flow, and it provides some amount of PEEP. For example, for 10 liters, you give a PEEP of around 1. So around 60 liters, it will provide OLI. So high flow nasal cannula will help here. And we also prone our patients very easily with high flow nasal cannula. But when high flow is failing, then we have to move to the last resort before mechanical ventilation is non-invasive ventilation. Your tachypnea is going up, respiratory distress is going up, patient is anxious, accessory muscles are working, the blood gas is showing you that the pH is decreasing, the PO2, FiO2 is decreasing, PaCO2 is increasing. What to do? We have to go for an NIV. This is our last resort. At any cost, we have to make this NIV successful. And there comes the hitch. Because NIV, we give the help of a face mask. There are 3 sizes of face masks present: small, medium, and large. But all over the world, the shapes of the faces are different. Can you compare the face shape of the face of Amir Khan with yourself, or with myself, or with Amitabh Bachchan, or with his edentulous women? It is not possible. So different shapes of the faces, but 3 sizes of masks. That is the reason of the failure of NIV in most of the places, and that is the reason why Italy was so successful in managing these patients in NIV, because they are using helmet. We know that face mask causes claustrophobia, skin irritation, so does the patients have a dry mouth. The patient cannot read, cannot wear a mask, cannot wear a specs. You cannot push a RALS tube. It's a very bad situation. You just sometimes put your face mask on in yourself. You'll understand how uncomfortable it is, especially those who are suffering from OSA. You'll understand. So we have a helmet in that place. The advantages are, it is having, you can use for a longer duration, better tolerance. Patient can look around, speak, drink, eat, cough, wear glasses, read, whatever they want, they can do. So more comfortable, and even you can do a prone positioning with this. But there are certain disadvantages. There are like greater patient ventilator asynchrony, CO2 rebreathing, and noise. So this can be very easily covered up But for noise, we are now giving earplugs. For CO2 rebreathing, I'll tell you what we are going to do. Now, if you are giving a high PEEP, see, what in NIV, if you give a high PEEP, that will expand your alveoli. That is our aim, to expand your alveoli. Whereas the nemesis of NIV with the face mask pass is high PEEP. Because the moment you give a high PEEP, the patient becomes intolerant to it. They will not accept it. Whereas the success of NIV with a helmet is high PEEP. Because if you give high PEEP to the helmet will expand. The moment it expands, it becomes very, very, that is less compliant and very easy for the patient to accept. That high PEEP I want, the patient is accepting it, and we have to inflate a cushion just below the helmet, and we have to give a low resistance circuit. We decrease the circuit length. Normally it is 120 centimeter. We decrease it to 65 to 80 centimeters. And we give a fast rise time. What is the rise time? Rise time is basically from EPAP, that is end expiratory positive airway pressure, to IPAP, that is inspiratory positive airway pressure. So expiratory positive airway pressure to inspiratory positive airway pressure, the time taken is the rise time. So that rise time will be very fast. So the helmet becomes tight, very tight, and CO2 rebreathing is abolished, and all these dysynchronies, asynchronies are abolished. See, this is a patient on helmet. See the comfort level of the patient that you're having. My resident is talking, he's asking whether you're all right or not. We have decreased the length of the circuit a bit. And he's telling, she's telling, yes, I'm getting. And see the settings that we have given here. We are giving it with the help of a ventilator, you can monitor the FiO2. We are giving a PEEP of around 10 and a pressure support of 15. That means 10 plus 15, 25 is our IPAP. And our EPAP is 10. PEEP is the EPAP here. IPAP is 10 plus 15. That is with the pressure support is 25. The helmet is well expanded. We have given a FiO2 of 50% here. The patient is so comfortable. He's asking. He's telling, I'm all right. So this is the magic of this beautiful device. Such an interface is, I don't know why it is not being used extensively in India, maybe up to the cost, but it is fantastic. Now I show another one. This is known as the venti helmet. Even you don't have to need a ventilator or a BiPAP machine. See, here the oxygen is coming from the wall and from two sources. And see, the patient. See the patient. So this is the advantage of helmet. But even with helmet, even with the face mask, even with the HFC, when we are basically losing our patient, we should not deny the patient a ventilatory support. Most of the time we tell ventilator, we will not give ventilator. Do not put the patient on ventilator. That is wrong. The more late you are doing, the mortality increases. So when we put the patient on ventilator, if the heart rate is going up, the pH is going down, your consciousness is going down, your PO2 FiO2 ratio is going down, the respiratory rate is going up. So this is known as the Hackard score. You can do it yourself. You can understand that within 1 hour the patient is going down, sinking, and your PO2 FiO2 ratio is going down. There are certain indices known as the ROX index, where if you don't have a PO2, at least measure the SpO2, the FiO2, and divided by the respiratory rate. If it is less than 3.85, how do we do this? Because we can well understand how patients are sinking, we intubate the patient and put on ventilator. And this is the situation then on the ventilator. We want here, we have to rescue this patient. So how to rescue the patient on ventilator? So there are two situations, as I've already told you, L cards and H cards. This is the happy hypoxia group. This patient can also go in ventilator. This is a bad situation where the high elastance is there, low compliance. This is the typical AIDS group. This patient will also go in ventilator. So here the lung weight, see the lung weight is 900 grams. Normally it is 800 grams. But here is the high lung weight, it is 2000 grams. So here we want more, we have to give more PEEP to expand this alveoli. We also have to decrease, we have to maintain euvolumia, and ultrasound will help a lot in that. We will not just give fluids to the patient, we have to restrict that. Here also, we don't want to overload the patient with fluids, that you have to keep it in mind, euvolemia. But here we can give a more of tidal volume. See, in the L type, you give a liberal tidal volume, low PEEP situation. Again, proning is always there, maintain euvolemia. But in this H type, you have to give a low tidal volume. The moment you give a low tidal volume, there is permissive hypercapnia. And the point is, hypercapnia is all its ill effects. See, hypercapnia, when it goes above 70, it causes increases mortality. So why should I permit a thing which increases mortality? So basically we are permitting it because it is our inability to decrease the PCO2. So we can give a glossy name of permissive hypercapnia. Do I permit robbery in our house? We do. So why should I permit CO2, increase of CO2 inside my body? Because we can't control it. So how can we control it? If the ventilator is taking care of my hypoxia, can I have certain situation where I can remove the CO2? If the ventilator can't do it, yes, we have. It is known as that is extracorporeal CO2 removal. Extracorporeal CO2 removal is like a respiratory dialysis. Many of these patients also go into AKI. And what we do, see, this is the video. We are doing extracorporeal CO2 removal in one of my patients. This is the CRRT machine. This is the patient is going on the, we are doing a dialysis here, that is slow dialysis CRRT. This is the neonatal oxygenator. Oxygen is coming from the source, that is from the wall, sweep gas flow. And what is happening here? CO2 is getting washed out from here. This is known as ECOR, extracorporeal CO2 removal. So if your hypoxia can be controlled, with this one, you can very easily remove your CO2. So this is one of the ways we can take care of our CO2. Similarly, here we have to give high PEEP. We have to remember the plateau pressure in your ventilator should not go beyond 30. Otherwise, it will cause a lot of amount of ventilator-induced lung injury. So you have to sequence your PEEP and your plateau pressure in such a way so that the driving pressure, which is basically the difference between the plateau pressure and the PEEP. See, this is the plateau pressure, and this is the PEEP. This is 0. You are giving a PEEP of suppose 10. If your plateau pressure is 30, so 30 minus 10, this is 20. So you don't want 20. You want around 50. So either you have to increase your PEEP here, you have to increase your PEEP here, you have to see why your plateau pressure is increasing. So you have to take care of these things so that you get a driving pressure of around 15. And remember, you have to prone your patient. You have to prone your patient, you have to sedate and paralyze your patient for maybe 48 hours and maintaining euvolemia. You have to maintain euvolemia. So even if your patient is not responding to ECOR, so and the patient's EtCO2, see the EtCO2 your EtCO2 is going up, the CO2 level is going up, and the PO2 is less than 80 millimeter of mercury for more than 3 to 6 hours. Maybe this is the time when you think of the last resort, that is extracorporeal membrane oxygenation. I'm not going to discuss ECMO here because it itself is a very big topic. But what I can say is that our take-home message should be: we should detect it early. We should deny ourselves from denying that yes, we don't have the disease. We should take appropriate medications at the proper time. Proper oxygenation so that the patient does not hyperventilate, the patient does not got P-ceiling. You should have to avoid patient-induced lung injury. We have to regularly prone these patients. And don't delay and deny ventilator if it is at all needed, because it will again increase the mortality. So I'll tell you, stay positive. Better days are yet to come, and they will definitely come. And again, I salute all of you, all the participants, all the panelists, because all of you are basically directly or indirectly involved in this war with COVID. It is not only ourselves, all of you are involved. So all my best wishes to you for the future, and definitely we'll meet together, not in this virtual way. We'll meet positively in a real way, maybe somewhere in India or outside the world, in the days to come. Thank you so much.
Yeah, outside the world.
Dr. Chatterjee.
Outside India, I suppose. I told you outside the world. Oh, maybe that is also possible. We are going to Mars nowadays. You don't know.
Dr. Chatterjee,
it was
thank
fantastic.
you very much.
It was fantastic. It was fantastic.
Chatterjee.
Thank you.
Dr. Chatterjee, thank you for this virtual bedside teaching in the ICU. It was a wonderful talk, very informative, and a lot of practical tips you have given to everybody, which I think all resident doctors in the ICU must follow and imbibe the teaching that you have given. I am sure you would make a wonderful teacher and a professor, and this talk should be listened to by all residents in all ICUs in India at least. A very important talk, and I thank you again very much. I don't think we have any questions. This was a very self-explanatory and a very good talk, so I don't think there is time for questions also. But if there are any questions, we'll surely, definitely, we can have them.
You can have one or two in the chat box, Dinesh.
Dr.
There are
Dinesh,
some in the chat box. One you can take.
Dr. Dinesh, this is Dr. Iwari.
Yes, Dr. Iwari.
I just highlighted in the chat box a common practice I am seeing: doctors giving e-consultation, starting steroids on the day 4, just on basis of without any evidence of hypoxia or anything. So I've put in a WHO guideline link which clearly says that steroids should be started only in those with critical or severe disease, not in the non-critical cases. And that has been very clear. But in practice, we are seeing a lot of people using steroids right from the beginning without indication, which can be harmful. So we need to somehow circulate these guidelines for the proper knowledge of practitioners. Over. Thank you.
I think what question is there in the chat box?
No, it's a comment. It's not a question.
No, there's from Vidushi. There is a
Vidushi, yeah.
So Vidushi, my student now is doing FICCM, I think fellowship in critical care in Lucknow. She has asked me cards versus ARDS. Any difference in oxygenation targets, sir? Early or late oxygenation targets, difference between subtypes, lower levels of oxygen acceptable. More or less I've explained this, except for the fact that lower levels of oxygen acceptable. What Vidushi is trying to say, if we can permit hypercapnia, why we can't permit hypoxia? Very simple. That is the question that she's asking. Yes, permissive hypoxia. Have you heard of this word, permissive hypoxia? It is also coming up very well. If I increase, and if I am not able to control my hypoxia, FiO2, even in the highest possible FiO2, I don't want to move into an ECMO or an ECOR, I can increase the cardiac output of the patient. If I increase the cardiac output of the patient with regular echocardiographic monitoring in my ICUs, then the delivery of the oxygen to the tissues will increase. And even with the FiO2 of, even with the SpO2 of 80%, you can achieve a delivery which is acceptable for your tissues. And that is the way you can, even with such a low FiO2, your patient will survive. So this is basically known as permissive hypoxia. The terminology came up a few years before. It's still, we are not yet practicing it, but definitely it is on the line. And if you want to do in your ICU, you can find something good. Thank you, Vidushi.
So thank you, Dr. Dinesh Jain and Dr. Ronaji Chatterjee for not only an excellent presentation, for a lovely discussion. As Dr. Dinesh Jain says, a lovely bedside teaching, and we had really heard it from the horse's mouth, from the frontline war, as I mentioned earlier. So with this, we come to the end of the 3 talks which we had planned today. And before that, I must thank the sponsors who make this possible, all the chairpersons, all the speakers, and of course the participants for their excellent interactions, their questions, which made it a very lively session. And with this, and of course we must mention all names of all the office bearers, including Debashri Chakravarti, as secretary, who has worked very tirelessly to make that, give us the technological support for this. So with this, I would request in the audience who are non-members of the MRCPI and FRCPI, if they want, they can leave. And we have a little ceremony for the new members who have joined us very recently in the RCPI and the Indian chapter. So, Dr. Shobhachaji Rai, would you like to say something?
Yes, I think at this point I'd like to say that those who before leaving, if they want to, we'd like to just say welcome to those people who joined late. And where's my photo? Uh, those who joined late, once again, I welcome them all. And you must have enjoyed a academic feast that went on for the last 2 hours. And I think what you missed out, amongst other things, is that our President, Professor Mary Hogan, President of the Royal College of Physicians of Ireland, sent a message for this particular webinar. So we'd like to play it all for you. So those who missed it, please listen to that again before we proceed further.
Hello, I'm Professor Mary Horgan, President of the Royal College of Physicians of Ireland and a consultant in infectious diseases. I was delighted to be asked to address you by my colleague and fellow Dr. Sabia from the Indian chapter. This has been a particularly challenging time for us as a profession, and indeed for the society and the people for whom we care. Never before has such a health issue affected so many people globally, and we all are learning as we go along. Thankfully, we're in a better position now in Ireland than we had been in the months of, particularly in March and April, where there was a considerable lockdown, which had a huge impact on the mental and physical health of our society, but also has had an economic impact. I hope that within the coming months and year, that a vaccine will help alleviate a lot of the hardship that the pandemic has brought on our societies. The pandemic has afforded us opportunities to learn from each other and educate each other through different platforms. Certainly within the College of Physicians, we have used the platform of Zoom to provide up-to-dates on all things COVID-19, which has been particularly helpful for those who practice medicine, not only in Ireland, but all our international colleagues. I'm delighted that Dr. Sabia and my colleagues in the Indian chapter have continued this with today's webinar on September 13th. I hope that you have a great learning experience and that these webinars will be the start of many more to come. Wishing you kind regards from Ireland and from all the members, fellows and trainees, both in Ireland and internationally. Thank you.
I would like to point out that what she said after that college has organized a lot of webinar on various specialties and subspecialties of medicine. So I suggest that you log on to the ICRCPI website and get onto those webinars if you wish to. Now, I will hand over to Mojid.
Sir, this is Shayab.
Yes.
Yeah, I just had I actually had a question for Ranoda. Ranoda, can you just tell me one thing? Actually, this is regarding one of my patients.
Can be done afterwards, not during the procedure. Maybe shall we carry on and then you can ask this question afterwards?
Okay, fine, sir. Fine, sir. No issues. No issues.
Now, so because
No.
hand over to Dr. Manoj Mukhopadhyay to proceeding.
So Devashish, our secretary from the Indian chapter office, is sharing the screen for us. We'll have the privilege of introducing to you our new members within the last 1 year, and there'll be a one-page CV, and you can see their picture, and we would request them, Devashish, if it's possible for them to say a few words.
Because I think we'd like to go through these briefly. each new members CV briefly first. Monojit, would you like to go through it?
Yeah, let it come up. The screen hasn't come up. So.
While we are doing that, can we have the picture of Dr. Avilash Tiwari? He is the first in the line. Is he available?
Yeah.
Screen taking such a long time.
Predictable.
Hello.
What about his CV?
I can't know why this. I think the internet is causing problems. Otherwise, it should have come up by now. Because it's ready actually.
Not sure whether Dr. Tiwari's photographs can be seen, but as you can see from the screen, he is sorry again.
Can't see.
Dr. Tiwari, are you online?
Yes, sir, I'm online. Can you hear me?
I can hear you now, but I can't see your picture. That's what I am just waiting for. Yes. Now I can see.
Can you see? Yeah. Okay, sir.
I think there is a light in front of you, behind you. So can you turn around?
Yes, yes, I'll do that. I'll do that.
Debashish, I can't see anything on this screen. I can't see anything on this screen. I think you need a...
Yeah.
Dr. Mukhopadhyay, are you seeing that?
Yeah. Okay, can you make it full screen for me, please? Okay, just let me say a few words about Dr. Avilash Tiwari, and then he can say something about us. He's a consultant physician and medical director at Sai Healthcare Hospital in Dombivli West. He's passed with distinction in emergency medicine. He's a member of the Global Association of Physicians of Indian origin and membership of the American College of Physicians, membership of AIDS Society of India, and his area of interest includes cardiology and diabetology. So can we have a picture of Dr. Avilash Tiwari, Debashish? And if you can say a few words.
Yeah, Dr. Tiwari.
Yes, sir.
Yeah, there you are.
Yeah.
See it. You would like to see us something about yourself or how you feel after becoming a member of the RCPI?
Yeah, I would like to share some important words, especially for the junior doctors who are attending it. I'm into the teaching profession. I'm taking a lot of lectures for the companies. I'm teaching a lot of MBBS students. And one of the most important thing which I'd like to share with everyone here is after doing the MRCPI, what I can find the major difference between our part of the training and the training what we have received from the MRCPI is that it makes you a better clinician. Needless to say, as we Indians are more academically sound, we may read page to page, cover to cover. But what the MRCP has taught us to be specific. They don't want a bulk of knowledge. They want what should be done specifically to a very specific situation. Like here in India, we read the volumes of big textbooks and the dinosaurs were extinct because of their sizes. And what I have seen in MRCPI, irrespective of what you read, what you need to do appropriately, it helps us to make you an accurate diagnostician and how to treat the patient on the guideline basis. Unfortunately, it is very sad to say that in Indian counterpart, though we read so many good textbooks, but very few physicians are able to apply the guideline-based approach, and the MRCPI training helps us to make a proper decision in managing the patient as per the lines of the guidelines and what is to be done for a particular situation is very important, and it has really helped me to become a very good clinician in my day-to-day practice. So really, I'm thankful to the college and especially the Indian chapters and specifically to Mr. Debashish Chakrabarty, who has helped me all throughout my journey. asking him so many silly questions, and he helped me all throughout my journey. So I'm really thankful to the Indian chapter, and specifically I would like to mention one word, that during the Part 2 clinical training program, they have arranged a practical examination scenario. And believe me, friend, that has immensely helped me in passing in first attempt when my exam center was in Dubai. I was a bit scared to go out in Dubai because seeing the patient in Dubai from India was a very different experience. And in the first attempt, I cleared it, and really thankful to the Indian chapter who has arranged the practical sessions for the students specifically, and that has really helped me out. So I'm really thankful to everyone, and wonderful for this lecture series, and I look forward that we should expand ourselves. We must have more academic activities, and we must increase our strength by remaining united. Thank you very much.
Thank you, Dr. Tiwari. Devashish, like to show us the next one. I think this is certificate. This is a certificate which will be sent to you, okay, along with the memento. Which we
Thank you very much. Thank you very much.
At the end, we can say that. Let's go to the next person.
Can we have Dr. Shubhadeep Pal and Devashish?
Yeah. Is he available?
Currently with Sharanya Multi-Specialty Hospital in Badwad as head of critical care unit over there. I'm sure he's enjoyed Dr. Ranaji Chattopadhyay's talk today. Okay, he graduated from Kolkata Calcutta Medical College in 1995. This diploma in family medicine, and then he's done postgraduate diploma in hospital and healthcare management. And his area of interest includes COPD, inhalation devices, and antibiotics, and cardiac critical care. So, Dr. Shubhadeep Pal, would you like to say something?
Before that, can you go through his CV briefly?
Yeah, I went through his CV. I didn't go into all the details, but I've
fine.
The main points, yes.
Shubhadeep Pal, not Pramanik. Pramanik is coming next.
Dr. Shubhadeep Pal.
No, but he is not Shubhadeep Pal. He is Shubhadeep Pramanik. Where is Shubhadeep Pal?
Yeah.
Oh, but he is Shubhadeep Pramanik.
No.
Where is Shubhadeep Pal? Is Dr. Shubhadeep Pal? Are you here with us?
Actually, he's not on the attendee list. Actually. Yeah, he is. Oh yeah, he is. But his video is shut up. So,
Dr. Shubhadeep Pal, can you hear us? No, I think something went wrong.
Yeah, his video is off, and there's nothing on the audio. Okay, let's go to the next new entrant. This is Dr. Shubhadeep Pramanik. Okay, beside his MRCPI, he's done DM in endocrinology. He's a consultant endocrinologist at Neotia Gatewell Hospital in Shiliguri, winner of the Endocrine Society of India Prize in 2018, in the Thyroid Quiz 2015, oral paper presentation IdeaCon 2017, has more than 20 publications in national and international journals, and is a reviewer in diabetic medicine and co-investigator in Sustain 8 trial. So over to you, Dr. Shubhadeep Pramanik.
So thank you, sir, for this opportunity to talk in this August forum. I started my MRCPI in 2014 when I was doing my MD in medicine, general medicine. But in between, I was a bit lost because of my DM training. So I completed my MRCPI in 2018 and 2020, the second and third part, after my DM training. And what I would suggest that even after getting taught for last 12 years in West Bengal, in India, the training at MRCPI was something totally different. It actually made me more methodical. It actually made me learn that how we should communicate with our patient and how we do counseling with our patient. And I have seen all those who have done that MRCPI, or for the sake MRCP UK also, their way of communicating with patients are totally different than those who didn't. And that actually helped me a lot for my own clinical practice. And obviously, the way of examining and the knowledge I got gathered while preparing for this MRCPI helped me a lot. I especially thank you and Debashish, obviously, because he had helped for me for last 6 to 7 years with all my silly questions and everything. So thank you everybody for making me a part of your community. In future, I hope I will be active member of your community, and I would like to be stay within academic institution. So thank you all.
Thank you, Dr. Shubhadeep Pramanik. Devashish, his certificate and your memento will be sent to you by courier. Next one. So,
thank you, sir.
Okay, thank you very much. Thank you, Dr. Shubhadeep. Our next new entrant is Dr. Briggs Sarvanan Ramachandran. He's a consultant gastroenterologist at Bharat Hospital and HGM Hospital, Kerala. And he's interested in upper GI and lower GI endoscopy and upper GI therapeutic procedures like EVL and lower therapeutic procedures like polypectomy, and has experience in ERCP for more than 8 years now. So Dr. Ramchandran, are you there on?
Yes, sir. Can you hear me?
Yes, I can hear you and see you. Okay, so you can carry on.
Yeah. Yes, sir. So, good afternoon. All the viewers and for the help have been praying a long time, and we interested for the meeting and expression in Japan. And so one gives help as other
Okay.
So
your voice is cracking. No, what you can do, you can shut off the video and see if the voice is there. At least we can hear you.
Voice breaker.
Yes,
Can you hear me?
Now we can hear you.
At the moment, it's okay.
Please carry on.
Thanks a lot for using ourselves, and like two member per chapter, and it's a lot.
Okay, try again, please. If you, it's better this time. No, the voice is going. No, I think one that is where you can shut up your video and see if the sound is okay or not. At least we can hear you. So, Prashida, should we? What should we do?
Actually, you can call a call. Can we call? No, I think you have to speak either audio or video here so that we can all hear you. But unfortunately, your voice is breaking. But perhaps you can just give one more attempt and see whether you can hear you. I hope that we can hear you this time. Try again, please. There's no other way. Devashi said there's no other way except going through this channel.
Off your camera. Just
he has switched off the camera. Please speak again and see whether we can hear you. Hello, Dr. Briggs? I think.
I say two lines about Briggs because he's a very good friend of mine. I'm Dr. Shubhadeep Pramanik speaking.
Okay, okay.
Start again. See whether we can hear you again now. Dr. Briggs, can you hear us? No, I think there is something wrong.
Okay. I think Devashi, do you have any more?
And I just
This is the last one.
see. Do you I start speaking again and see whether we can hear you? No. Unfortunately, you can't. Well, perhaps you can write to us. That would be the next alternative. We can see you. We can communicate. Cannot communicate. But basically,
You can post it chat in the.
you can post a mail to us, and we can hear your statements. You can't hear your statement, so you can post your statement. Okay.
Okay, Devashish.
Yes.
Maybe
No,
to us his certificate and his memento, and then maybe
Yes.
the last one will round out.
Yes, I think.
Okay. So that's the last one, is it?
Yeah.
Okay, Dr. Ray, do you want to say something, or should I
I think
wind up the program?
you have said all these new members who is not that new. Actually, two of those four persons were very communicable in our WhatsApp group, but then Dr. Subhadeep Pal, for some reason, is not available. But now you are officially inducted. You were part of us before, but you are officially inducted, and you are definitely, we expect you to be more active in the days to come by, and perhaps you will, when these COVID days are over, as soon as possible, we hope that we can meet and have the good. And until then, we can meet virtually like that before in future. And I think the next, Dr. Onajit Mukhopadhyay will announce the next next three webinars. You got the date of the next one. Onajit, do you want to say something on that?
Yeah, I've the next date is the 11th of October. It's again a Sunday at 11 in the morning. We are hoping to have 3 talks again. It'll be a star-studded session. What I see in the RCPI, everyone is a star. It's that every month we'll give the opportunity to 6 to 8 of the stars to shine brightly, so that by the end of the year, when the full circle is completed, almost everyone will get an opportunity to talk or chair a particular session. So what we have planned one for diabetology next time. I was supposed to do that session, but the sponsors has backed out, so we have to look for another one.
We have to figure out the plan and post it within the next 1 week. We have to plan the next one, and I think I would invite everybody to give their feedback, criticisms, constructive criticism for the better organization of the future ones. And I think that's probably all we have to say today. And I think I would like this panelists to be here now to discuss a few things before we say goodbye to each other.
Oh, thank you. The final program will be given to you in a few weeks, in a week's time, probably. Yeah. Okay. Thank you. Thank you. So we request others can leave, or we want the.
We'll have a few minutes discussion between us. So, Dominic and Dr. Briggs and Avilas Tiwari will be talking to you later on, either by video call over phone, and then we'll take it further. Okay.
Okay. So we have a feedback form with the fill in, but I think we can't fill in the panel as a panelist, but others can fill in the feedback form which is coming up. Okay.
Feedback to the Mukhe, but you can send the feedback later on. Not. Do you want to say it now? Even you can send the feedback by email, other than just doing that.
Okay. So I think we come to the end of the first CME. Personally, I feel it was very successful. Of course, technical hitches are there. I mean, it's always part of every CME, And I think we've done very well, considering it's the first time for us. Only thing I was discussing with Dr. Ray is that we would like someone from from Dublin to join us, but unfortunately because of the time, because you see 11 in the morning, it's 6:30
I saw Dr. Chadwick
in Dublin. That's a bit of a challenge. That's the reason.
Dr. Chadwick was there. Dr. Chadwick was there.
No.
I saw him.
You saw him?
His name. I saw his name.
He logged in.
In the participants, I saw Dr. Chadwick's name.
Really?
Yes.
That's very unusual. Quietly came and went.
Yes, I saw his name in the participants.
Okay, Devashish will give us a list.
Devashish
If he was there, we could have asked him to comment on the respiratory part at least.
Yes.
I think
I don't know whether he's still there or not.
No, name is not there. I was looking at the attendee list.
But I have seen his
not there.
Now it is not there, but he was there. When there are 41 or 42 participants attending.
At one time there were 50. At one time there were 50.
There are 50 also, yes.
So that is the challenge. But anyway, we can get a recorded.
I think out of our panelists, we only have some of us, but Dr. Sagorika has left.
No, he's there. She's there too.
Still there?
Yes, she's there.
Dr. Dinesh Jain, would you like to give a feedback or any suggestions?
This was an excellent beginning, and we should keep up the tempo. And we had very good talks actually. So I think we can have more variety in the coming months and more participants. The biggest problem actually with the webinars is because too many webinars has become very limited, everywhere with most of the webinars. So people who are actually interested in those topics, they only attend. Actually, that's what I am seeing. That's a trend I'm seeing.
Yeah.
So anyway, we should continue with this thing as clinicians. We have a wider spectrum of topics to discuss. So I think we'll have more attendees than societies having their own webinars. I'm sure about that. We need to publicize a little more. More publicity is required for our webinars, actually.
How do we do that?
I think we'll send it to, we all are members of various other societies, So actually, I sent it to the API chapter Delhi, to all the people, on our group. Then I sent it to the group in Pune and, other places where I am a member of the groups. So I suppose some of them must have attended, I really do not have the list, but I'm sure someone must have attended from those groups, whoever was interested in the topics, But it is a very good beginning. And I congratulate the whole team in Kolkata, Dr. Ray, and everybody, Dr. Manoj, and everyone has actually chipped in their bit, and it's really been a wonderful experience. And all the topics and talks were excellent, I'll say. All the talks were excellent and very interesting. And they were of a practical nature, That is what we need in internal and clinical medicine, We have to have a wholesome viewpoint of all the things, So all the best for the future. And
this is also an opportunity for us to meet in virtually. It's next best to see each other in person without coming by to Kolkata or me going to Delhi. But then I think I would like everybody, we'll chat now, that at the end of the day, everybody should think about a praise or criticism, constructive criticism, how by mail or WhatsApp,
Definitely.
This now. And the rest, now we go to the next person who is going to comment.
Dr. Barara, Sanjay Barara is there. Actually, Dr. Barara is there.
Where are you? Sanjay? I can see Sanjay here somewhere. Where are you?
No, he was answering someone's question.
Okay. Now, who else? Who is the next person? Sagorika, to give us your feedback as a whole, and how do we take it from now for the future? You're mute. No.
I unmute. Yeah, can you hear me now? Yeah.
You spoke very well. Your talk was excellent.
I thought that there might be some problem or the other, but there has been just seamless delivery. And the presentations also were very crisp and absolutely on time.
Good, good.
And we had
Your
a
talk
good
was excellent.
presentation as well.
Yeah.
Okay, good. And I think thoughts for the future, Sanjay, you were not in the team working or arrangement team, but you came in the right time and you delivered. Please tell us what are your tips for the future.
So I think it was very good program overall, and I think you worked very hard. Everything was very, say, point to point. You just made a dry run first day. It is very, very unusual nowadays to anybody's working so hard to have a dry run complete and everything. So it was great. Congratulations. My suggestion is that we should take diverse talk like this time also similarly, and we can include according to the people from various specialties or various say fields. Like osteoporosis we can bring out in picture gynecologist, we can bring out picture the orthopedic surgeon. Similarly, we keep a talk on say steroid related issues, we can bring the rheumatologist, we can bring the orthopedic surgeon, or those are using lot of this kind of drugs. So we can plan in advance, we can inform, and we can keep one or two chairperson rather than one chairperson. Sometimes it will be otherwise also say backing is there, and more input will be there from various places. Like especially I suggest one person from maybe academics, one person from the practice, so that is kind of good information from what practically is important, why academically is also important, something like that.
I think your suggestion is very well taken, but I would like you to drop in a few lines via WhatsApp.
Yes.
We will be discussing that to see feasibility of it. Thank you.
Yeah.
Next, who is the next to that put question, their opinion from
Sagrika's talk and Roy's talk was good, and Dr. Rana Chatterjee's talk is actually excellent, very, very practical. Congratulations, sir.
I think
Thank you, sir.
he knows the subject too well for us. He's actually
all three talks were too good, and Dr. Sagrika's talk especially, I don't think so many differences. I never thought of it. So many differences in men and women diabetes is there. And Dr. Roy's talk is difficult. Thyroid nodule to cover in 20 minutes is difficult. I am sure that was very good.
Very difficult.
I think we should really have a meeting within the next fortnight to decide how and when we should go for the next ones. It still looks as you said that we should cover a lot of topics, but I think that we fortunately for the future topics we do not always need sponsor because the cost is not that much. We can have sponsored talk, also non-sponsored talks. So that, because we emphasize more on the subject, like next time we have in consideration of rheumatology and anemia, which is everybody's ball game.
Rheumatology, yeah.
Those may or may not have any sponsor, but even if it doesn't, we should carry on with the actual topic, and which is more our day-to-day problem than otherwise. So I think it's a mixture of both. So we'll see how it goes on for the next time.
Okay. Thank you, everyone. Thank you for making it very successful.
Let's make it call it a day.
Okay, yeah.
Thank you so much.
Thank you, sir.
Thank you very much.
Devashish can have a picture like this, screenshot, and can share that screenshot.
Devashish,
Yeah.
you can put all the pictures over here. Devashish might be.
What I understand that the whole program is in
Recorded.
YouTube.
No, and all our program are recorded. I can share in the.
No, but can we have all the pictures in one screen?
But at the time when everybody was there, not
not all, but at least the panelists are here. We can take a picture now.
some of them are not here.
Some of them are not here, yeah. But you should take it at the beginning then. You will decide and take it at the beginning, yes.
So I can do one thing. I can just take a simple picture and I can just post it.
Devajit, can you put all of them now? Can you put them all in the same screen?
I have taken one screen. I have taken one shot.
Okay, three cheers and 3 cheers for the Indian chapter.
I'll be posting that one.
Okay.
So you're putting Mary Organ in that?
Yeah, this photographs I have taken.
Okay.
I have posted.
Posted one in the group. Thank you very much. Thank you.
Okay. Thank you.
All right then.
Okay.
Okay, bye. Bye, sir. Bye.
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 Yeah, stay safe. Stay safe. Okay,
Yeah.
everyone. Okay. Thank you. Bye.
Bye.